Audio may not be fully recorded. How can I go under your? Maybe that can be in two places at once. Who is Natalie again? Natalie Rugley? Who is that? Somebody new last week. It's somebody's girlfriend. Who is it, Nathan?
I believe it's Brett.
Okay.
Thursday, by the way.
Only person I'm looking for is Isela. Isela, are you here?
Yeah, I'm here.
Okay, great. Okay, then everybody's here. We'll go ahead and get started. Welcome to week 2. I know it's confusing, isn't it? Because it's Tuesday, right? It's the end of our week. We'll be starting week 3 tomorrow. What's that? Is there a comment? Okay, I heard.
No, I was talking to my daughter.
Okay.
I was talking to my daughter. I was unmuted.
Okay, that's okay, Monique. Yeah, so welcome to the Littles. I see a couple in the corner there. What's your daughter's name, Mariah?
Scarlett.
Scarlett or Charlotte?
Yeah.
Scarlett.
Scarlett.
Uh-huh. Hello. Okay, so this week, week 2, we're going to discuss the Josie King video. Great discussion. Thank you for participating in that. And I know there's always more to the story, right? But we'll talk about the things that based on, you know, the mother's report, right? Which, you know, we have to remember some of the facts, right? A child died as a result of, you know, being cared for at Johns Hopkins in the pediatric unit, right? So this happened. And then out of that, and, you know, Johns Hopkins did allow this mother to tell her story, and they accepted responsibility for it. And then out of that came, you know, reports of, you know, developing rapid response teams and looking at issues of communication and safety with families in the healthcare system. So out of that incident came a lot of changes in healthcare. So that's why I wanted, you know, it's kind of a landmark, kind of a benchmark study in, you know, change in healthcare practices. So I think it's kind of a good tradition for us to look at the Josie King video in that whole instance, even though, yes, there are details, right, of the case that weren't disclosed or discussed in these videos. So I know that's frustrating to you when you're wanting to like really drill down to the root cause. It's like, what was the staffing like that day? What were the doctor's orders like? Were they recording I's and O's? Were they recording vitals? Was she on a monitor? All good questions, all things that make me you know, identify that you know how to critically think. Those are all changes you would make, right? You'd make sure that you're assessing, right? And understanding that your critical thinking starts with assessment. So, you know, I think it's good that you bring up those details, but then also needing to step back and say, okay, what do we know just from the mother's, you know, what she experienced? Because her perception is her truth, right? That's how she perceives what happened to her daughter. So, you know, just listening to her story, and you know, we'll discuss that first. So we're going to discuss the Josie King discussion board a little bit more and share your ideas. And then because, you know, chapter 6 is about values and advocacy and ethics. So I like how this, you know, that experience of that mother ties into, you know, I think Sarah, you commented on, you know, the morals of the nurse. So, you know, how do we look at that moral dilemma that's created when you might be in an environment that's not comfortable for you, or, you know, doesn't have maybe that that work culture that you're wanting. So I like how you kind of pointed that out in your discussion. And then we're also going to look at culture and diversity and how we provide a cultural, you know, competence in our practice, and how do you do a cultural assessment. I think, you know, it's really good to take a class session to look at culture and spirituality, because that is a section of the assessment that you're going to perform on your clinical patients. And I think it's always an area that students kind of confuse and don't prioritize sometimes. Maybe even nurses on the floor really don't prioritize it because it's not a physical, right? A physical, maybe prioritized nursing diagnosis. So They're not really prioritizing the assessments and the assessment findings. And I got to tell you, in 30 years of nursing, when I would, on our admission form, it just said, do you have any cultural concerns or preferences? If you would just ask that question of your patients, they would turn to you and say, no, because to them, their culture is their norm. So they don't realize it's like you might say, if I said that to you, you know, if you went in the hospital, would you have special cultural considerations? And you'd probably say no. But what if you were in France or in another foreign country and you were hospitalized? Then things might be a lot different, right? You'd be speaking English and maybe they're speaking another language, and you know, everything would be different, right? The food, what if they were serving you snails or something like that? You'd be like, I'm not going to eat that, you know? So, you know, there would probably be a lot of cultural, you know, concerns. So well, you know, when we think about it in that aspect, and, you know, providing cultural competence in an environment that's becoming more diverse, right? And looking at those racial and cultural diversities in the United States and how we can't provide quality nursing care if we're not speaking the patient's language and teaching them in the language they can understand and paying attention to their values and their beliefs and incorporating that into patient-centered care. Okay, so I'm going to lecture on that. We're going to have a breakout session where I'm going to put you in groups and you're going to do a little role play activity so you can practice these techniques for performing a cultural needs assessment. And then we'll meet back and hear those role plays a little bit for some fun. Okay, so it's not just me lecturing for 3 hours. That gets boring. Okay, so I have some questions for you to start out. What do you think is important in providing communication? So therapeutic communication, to have good communication, what does that take? What are your thoughts on that? Kaylee, what do you think is important to good communication?
Like listening to the needs of others, really making sure you have that common understanding, and that would lead to like providing that need for that person. Just having a good sense of listening, I guess.
Very good. Yeah, listening is key, isn't it? And I think almost every response to that Josie King video commented in some form on how there was that lack of communication and how they weren't listening to the parent, right? And how the mother was, you know, voicing these concerns and how this wasn't normal for her daughter, and they just didn't, and how frustrating. I think almost every good movie out there, how many movies have you seen where that's kind of the angst of what's going on, is that something's being said and nobody's listening to, you know, they keep walking into that house and there's killers inside and they're going to get you, but why don't you listen, you know, or listen to your gut even, right? You know you shouldn't go in there, but they do it anyway, right? Well, they're, you know, and so same way, right? The staff wasn't listening. And one of you commented that better safe than sorry. And I thought, wow, yeah, that is a profound statement and so true in this case, right? But better safe, right? Always safe. And safety is like number one. It's rule number one. And when you talked about how the leading, like the number, you know, the third leading cause of death is medical errors. People go in the hospital to have, you know, their healing facilitated, and then what happens if there's medical errors, and right? So what are some of the different mistakes? What are some of the different errors that can happen in healthcare? And what was interesting is in one of the comments, one of you commented that people are human. People are going to make mistakes, right? And in the Institute of Medicine, which has now changed its name, the big, you know, benchmark kind of publication that came out was To Err is Human. And how can we look at creating safe environments where people, healthcare workers, will come forward and report medical errors for everybody's learning, so that you can look at why did it occur and fix it before other people make the same mistakes, right? But that culture still needs to change. It's still, I think still people don't want to report mistakes. And we see that over and over again, that there still is consequences of reporting mistakes that staff try to avoid, and the patient is harmed because of it, right? So, so I liked that you picked that out, that, human beings are going to make mistakes. We're going to look, two people can look at the same thing, with their eyes and see the same wrong thing on there, right? And still make a mistake. So how do we look at changing processes to use informatics, right? One of your cues and competencies is the use of informatics. How are you going to use computers and tools and equipment safely to help you gather data and critically think, to look at trends and processes, to help you not miss things and changes in your patient? So what are some of those errors? So what,
Miss Erickson,
yes.
sorry, real fast. One of our students is actually trying to get in the class. She's in the waiting room right now.
Okay, I'm sorry, I'm
Sorry.
not seeing her. Let me find her. Aha, I see her. Okay, thank you.
Mhm.
Aha. She was, Tamara, you must have been in and then you must have got kicked out because I thought I let you in once. So sorry about that. Thank you. Thanks for pointing her out to me. Okay, so what are some of the mistakes? We could say error in communication, right? So we got that. Now, like rule number 1 in pediatrics is listening to the parent. So I was going
to say advocating for the patient, and in pediatrics that often means advocating for what the parents are letting you know, because they know their child better than anyone. So if something is going wrong and they can see that, then taking what they're saying seriously.
Yes. Yeah. So error in reporting, right? Reporting mother's concerns.
I was going to say using your memory rather than what's in front of you.
Okay, and what error did that lead to?
We were specifically doing the Josie King case or just in general?
Yeah.
Oh, my apologies. I thought we were just talking about errors in general.
Well, okay, what error in general is from going by your memory?
So if you are going to give a drug that maybe counteracts something else, and you assume that you know what is going to be given, and you rely on your memory, and you could really harm the patient.
Very good. Yes. And there's studies that indicate that even, very experienced nurses, that they shouldn't trust their memory. They should always look it up, right? So how do we quickly do that? How do we incorporate that into our practice? What's a way, what do you think would be a way of being able to do that?
We're discussing.
Go ahead.
We're discussing our 3 checks and our 5 rights, and what Morgan said, charting. So keeping track of every single thing that happens.
Yes. Yeah. And when you go to give a medication, there's a med lookup icon in the computer that you can click on in DocuCare. You can, when you go to the medication administration record, you can click on the med lookup and it takes you into DocuCare, and you can look up the medication right there at the bedside. While you're doing that, you can share that information with the patient and educate them on what you're giving and why you're giving it and the dose that you're giving, and verify it with your patient, because how many times do you think that happens at the bedside? That the nurse says, here's your blood pressure medicine, and they're like, wait, that's not my normal dose. I don't usually take that much. Do you think the nurse should go ahead and give it anyway? No, you stop, you listen to your patient, you go back, you tell the doctor, hey, they say that they only take 25 milligrams, not 50. They normally don't take this dose until at bedtime. So, calling pharmacy and retiming the dose, making sure it's at the right time, the right dose, the right route, the right med, all those, the different rights. So there's many different ways we can make medication errors. We can give it for the wrong reason, which I think, that happened, right? The mother had the right. Does the patient have the right to refuse? And in this case, it was the mother. If the mother refused the dose and the nurse gave it anyway, right there, you identified that was a med error. She shouldn't have given the medicine. She should have allowed the mother to refuse it and go and notify the doctor. Then that error wouldn't have happened. And it was a multitude of errors, wasn't it? I think that was the frustrating part. Those of you who dug a little deeper, you read information about the central line infection also. So she had her line removed because they thought Now we don't know, was it truly infected, or were they just removing it when she came out of the PICU to prevent line infection, which is a standard of care. But then they didn't.
Sorry, from the research I did, they specifically removed it because it was infected. The initial report, which is what most of the mothers' first speeches were on, were based on the idea that the methadone injection played a significant role in her death. But upon further review and issued in 2010 was a reissuance of her cause of death, and it was attributed to that infection, sepsis from that infection, and the dehydration. The quickness with which she coded after she was given the dosage doesn't allow for the medication to have played a significant factor. Maybe a small depression in a respiratory rate.
Very good. Yeah. So that's another area of medical errors, right? Nosocomial infections. Anytime your patient has a catheter, urinary catheter, central line catheter, surgical surgical site infections, incision infections, any time that they develop MRSA in the hospital, the hospital's liable. That's where the hospital could be negligent, right? So they came in without that, they acquired it in the hospital. So whole nother area of errors that can be made. People who develop skin breakdown while they're in the hospital because so errors of commission and errors of omission, right? Things you didn't do that you should have done, and things that you did directly that caused harm, right? Using a piece of medical equipment that malfunctioned, that maybe should have been questioned, had a frayed cord or something, or an IV pump that had infiltrated, on a patient, and then they didn't remove that pump and have it serviced properly. So there's all, it's amazing with all the mistakes that can be made, that more things don't happen. I feel like sometimes you'd come in the morning and you felt like it was booby trap after booby trap in a way as a nurse. Like you'd walk in and you were getting an admission in a room, and there'd be an old suction setup still sitting at the bedside with gross secretions. That actually happened to me on a day when the health department was surveying the hospital, and I was getting a tonsillectomy post-op, and I went into the room to check the room to make sure it was clean and ready, and there was an old suction canister full of secretions there. And I freaked out for one moment, and I just quickly changed it out and got the room re-cleaned and everything. And then the patient came back post-op, and wouldn't you know that health department surveyor came on the unit and went in and interviewed that mother who said, the care here is awesome, right? Versus I came to my room and there was a dirty suction setup at the bedside, right? Couldn't that have gone in a whole different direction? But for the grace of God, go I, right? Because what made me just kind of think, oh, I better check that room, right? I mean, here's a good answer to that. Because I do that every time, right? When you get in the practice of doing certain safety precautions every time, every day, every patient interaction, right? That's your standard of care. You go in, you check the monitor, you check the alarm limits, you check your IV fluids, you check the tags on your, the labels on your tubings, right? And you're looking up your meds every time before you give them, and you're testing your bag and mask. You're making sure that your appropriate size bag and mask is at the bedside, and all of the code sheet's correct, the patient's name band is correct, the correct allergies are on there. See how it takes constant vigilance and knowing what the standards are on your unit, okay? So if the standards are to get post-op vital signs every 15 minutes for the first hour, and then every hour times 4, you're doing that, and that's documented, and you're reviewing those vital signs and looking for changes. So it does really take constant vigilance, because the one time that something happens and you get distracted, and then there's a change in a patient that you don't pick up, that's when the Josie King thing can occur. And doesn't it take teamwork, right? Where were all the other nurses that maybe were going in there? Weren't other nurses in and out of that room? And What about the physicians that had gone in, and, you know, why didn't they identify? Why weren't they reviewing the chart and looking at labs and things that could have clued them into some of these? You know, wasn't there a change in her white count with that central line infection? So it does make us want to ask those kind of questions, doesn't it? Okay, so some other errors, right? So
that was actually one of the errors I saw in there, was when the mom asked for a second opinion from a nurse, and the other nurse came in and just backed the first nurse, because, you know, that's what's going to happen 90% of the time. And then, you know, they still didn't pay attention to the kids' dehydration and stuff.
Right. So one of you did, you cited there was a report on the substandard practice and Josie King, the patient safety movement that came out of Zena, right? Zena, didn't you cite that study?
Which one? I'm sorry.
How Josie King, the patient safety movement that came out of this whole event?
Oh gosh, I don't remember.
Because I know the adverse error reporting and rapid response teams came out of this. So do you know what is a sentinel event? So what's the difference between having an adverse outcome or a incident report that needs to be done? So a regular incident versus a sentinel event.
Sentinel events are events that should not occur.
Right? That usually they cause loss of life or limb, and should have never occurred, never happened events. Yep. And that term sentinel means like sound the alarm, right? So those are reports then that are going to get reported to regulating committees, and then recommendations are going to come. So that data is going to be shared nationwide. Things like connections between suction catheters and oxygen delivery devices and IV syringes and oral syringes. So back in the day, a nurse could take a regular Lurlock IV syringe and drop an oral med like oral Tylenol and walk into a patient's room and grab the IV without thinking, because maybe she had some IV Lasix and, you know, another IV morphine for pain, and then she had this oral Tylenol. But she accidentally had the syringe with the oral Tylenol and pushed it in the IV and killed the person. And you think, oh my gosh, how could she do that? You know, that's absolutely a mistake that should never happen, right? Somebody shouldn't be able to walk into a room and give oral Tylenol IV and kill somebody. But it obviously happened because it got reported nationwide. And then the recommendation was as simple as switching to an oral slip tip syringe for oral meds, so that connection was incompatible with the IV ports on the IV tubing. So those oral syringes were orange, and it was difficult when a nurse would drop oral medication to see if there were air bubbles in there or if it was all medication. So a lot of nurses just thought, I don't like those orange oral syringes. I'm going to continue to use IV syringes for my oral meds. So on pediatrics at TNC where I was working, I was like, no, you guys, you can't do that. I know you think you're not going to give it IV accidentally, but guess what? It's happened somewhere, somehow. So if you were to happen to make that mistake, that would be a huge we have to change the practice. We have to use the oral syringes. Just get used to holding it in the light and making sure that you got your complete dose there, right? So, and making sure that you have oral syringes stocked, and those, so when you implement a change, you've got to make sure that that change takes place and that, you make that transition to that new practice, right? Doesn't it take like 30 days of doing something every day and then it's a habit, right? Old habits are hard to break. And it's hard to incorporate new practices. It can be, right? But all it takes is knowing the why, right? The importance of how it's going to affect patient care and how it's going to protect your license also. Because if you're not giving, the new evidence-based practice, if you're not practicing a high standard of care, that puts you at risk when you make an error, because you want to be prudent, right? What does it mean to be prudent? So you know how, yeah, Chanel? Was that I know.
To be prudent is to make sure that you're always checking up on like being on top of things and make sure you're ahead of the game. And it's like what we do with our Blackboard every morning, make sure that you know exactly what's coming up for the class that day.
Right, and if you got up in a court of law, they'd say, what would most nurses do in this situation? Would most nurses who were taking care of Josie King identify that sucking on a washcloth in a patient who was NPO with no IV fluids, and a mother who was concerned that she was screaming that she was thirsty and maybe I'd like to know what her urine output was too, right? And what was her cap refill, and what was her blood pressure, other signs of dehydration in this child. Wouldn't most prudent nurses pick up on that? So that's like your basic standard, what would, the prudent nurse do in that situation, that prudence. So, yeah. And then, and I know a lot of you talked about being non-maleficent, right? Not causing harm to the patient. So, you go in and you refuse to lift the patient on the draw sheet, right? And you decide you're just going to pull them up. Everybody's busy, so you're just going to go up and pull that patient up yourself, right? And then they get a shearing injury. I think most of us would agree that that would be maleficent, right? Am I saying that right? Maleficent? I don't know. I got to go back to that medical terminology book. Have you ever played the voice of God on there and it says maleficent, causing harm in your patient? Segment's Medical Dictionary has a audio feature for you if you ever don't know how to pronounce something or want to come back and show me how to pronounce it correctly. So, okay. So other rooms for error. So how about wrong surgery? Wouldn't that be wonderful? You go in to get, a tubal ligation, you end up with a hysterectomy or something. Wouldn't that be nice? So, we've had patients get wrong knees operated on. Now they write, not this one, this knee, right? That kind of thing in surgery. So consent, informed consent is really important. What procedure have they implemented during procedures that help prevent those kind of errors from being made? What has been a change in practice?
Timeout.
Timeout, exactly. So what do we do for a timeout? And how do you know this? Share your experience here.
My husband has had a bunch of surgeries and he's always like very cautious before he goes in. Like he'll ask like, are you guys gonna do timeouts? Like how many timeouts do you do? And so they're like, oh, okay. Just to ensure that they're doing it in the correct limb.
Very good. You know what I like about that too, Vivian, is how you're saying how your husband got involved in his own care. And you see how more informed patients are becoming as patients hear about these errors, right? They know when they go into the hospital what to watch for these safety practices. And they're starting to expect timeouts. They're starting to expect that you're going to label their lab specimens at the bedside. And they're definitely expecting that you're going to know what medications you're giving them and the basic side effects and adverse reactions they should watch for, and that they know that you should be asking their name and date of birth and their allergies as patient identifiers, right? And identifying them before they have procedures and things, being done. So I think, and they definitely know that you should be washing your hands before touching them. That was one thing that we started as an initiative. I think most organizations have had is, it's okay to ask. It's okay to ask me to stop and wash my hands or clean the equipment before I'm using it on you, empowering the patient. And what do you think about that? Does that develop trust with healthcare professionals? Does it make health professionals feel like they're being questioned? What do you think, Alexandria? Do you think it's a good thing or?
I think it's a good thing. I think that sometimes people get upset when people question like their education, but I think that it's important not to come at it with that type of attitude. Just like, you're working on another human being and they have the right to be a part of it. And if they want to question you, it's because they're looking for answers. And like, that's how you could continue to build the trust with them.
Absolutely, right? I think when a patient asks something like that and you stop and you acknowledge and empower them and tell them that's great that you're doing that, and I will absolutely look, I washed my hands before I came in, but I'm going to wash them again in front of you because I'm really glad to see you involved. I think that you're absolutely right. That establishes more trust, and it demonstrates that you care. Then they're going to feel more cared for. If they feel like you're being defensive in any way, I think that's going to, so we're seeing that, even having families at the bedside during code situations, and that, that kind of transparency does establish more trust.
Excuse me, Mrs. Erickson.
Mm-hmm.
Ms. Erickson, did you see my chat just so that we're on the same page if I'm in and out?
Okay, I'll check it out.
It's been like an outage here in Marana, so if I'm in and out, my internet is so shoddy right now.
Okay, and you guys know that I'll try to go ahead and post, the link to the YouTube and download.
Okay, yeah, just so you don't think I'm like not here. It's just,
okay.
Yeah, it's been crazy.
You bet, no problem. Okay, so wrong surgical sites, nosocomial infections, of course, med errors. What are the rights? Alicia, what are the rights for medication administration?
You've got right patient, right dose, right route. I don't remember the rest.
Okay, patient, dose, and route.
Time.
Right time. Right documentation, right reason.
Right medication.
Right, yeah, right med. I think, did we say med, dose, route, patient? Okay, time, documentation, reason, right to refuse.
Right outcome.
Right outcome.
Do we say education? Right
education. See, we could keep going. There's more. There's obviously more than 6, isn't there? Right procedure in checking it for interactions, or other things like double checking dosage. Sometimes you need to verify the dose with the second nurse. So all those things. Okay, very good. So communication errors, medication errors, omission, commission, documentation errors, right? And communication. And then of course, equipment errors, watching for, making sure your IV infusion pump is working correctly, the bed's working correctly. Okay. Talked about how listening is key for effective communication, making sure that we're communicating in a language the patient understands. Okay, I know there was also a little bit of discussion about, other factors that could have played a part in the case, right? Questions that we had about, I love how they didn't really go down the path of explaining why the nurse was acting bizarre and why the doctor or somebody didn't follow up with that, right? We'll never know about that. Did you find out anything on that, Tom, when you investigated further? So either there was nothing to that, or that was kind of protected information or something that was dealt with in another case, right?
I'm sorry, can you say that one more time? My daughter just messaged me. She's out running around.
Okay, I was just wondering if in your further research, if you found out anything about the nurse that was behaving oddly. Okay.
No, I think they kind of distanced from that
because his house
pretty quickly.
He's working at his neighbor.
Was somebody else sharing in the background there, or just not?
No, that's my daughter talking on her Zoom meeting.
Okay. So the other thought that I had, just in my experience too, is I was wondering if, because of the daughters of Josie's initial injury being that burn injury like that, if CPS was involved, DPS was involved in her case, if there was any fault on the part of the parents, or if the parents were kind of defensive. Like sometimes I think when nurses aren't listening to a parent, or that was just something that I felt like, if I was investigating the whole situation, I would want to know, why were the nurses encouraging her to go home, right? Why weren't they listening to her? What, was there some, did the mother feel kind of defensive? Was she a difficult parent? Were they kind of avoiding her for some reason? So, I think there's as we look at culture and beliefs and values and things, I think sometimes we all do have our biases, right? And, you know, if somebody thought maybe this mother was abusive or, you know, difficult, that could be a reason why they weren't on the same page collaborating with her and listening and supporting her. And then what happens? Poor patient outcome, right? So you really do have to think about the patient. I think sometimes, you know, people who don't work in pediatrics, they say, how can you work with, you know, families where there's abuse and things? Because you're focusing on the safety and the outcome of the patient, right? So you do. I mean, your gold, your North Star, right? You always think about the patient first. So if that's always, you know, your focus. I think sometimes for students, you know, you go into clinical, you start feeling nervous, right? Because you're thinking about yourself. I mean, not to, if, you know, of course you're going to a little bit, right? You're going to think about what you're doing and, you know, did I remember everything and all that? You start to get a little nervous and anxious. But when you think about the patient and meeting the patient's needs, and all of a sudden those nerves kind of go away because now you're thinking about the difference you can make and what you're going to do, right? So that was one of my thoughts, was, you know, what was that relationship with the family and that. So one measure that we can take and that we do is to do patient and family-centered rounds, right, with the whole team. So when the doctor and the nurse and the charge nurse and the pharmacist and the therapist, everybody who's involved in that patient's care can go in the morning, and the first thing that they say, have I ever already talked about this at all? No? Okay. Wanted to make sure that, so, you know, changing those kind of practices where you have a family-centered care rounds, go in and everybody introduces themselves. You know, this is the physician, this is the resident, this is the charge nurse, this is your nurse, who hopefully they know. And then they turn to the parent and they say, how do you feel your child is doing? And then they listen. And then they'll discuss, what is the goal for the child to be able to go home? You know, does the child need to be weaned to room air? Do they need to go to every 4 hours on their aerosols? Do they, you know, want to be able to tolerate a regular diet, be afebrile, not have a seizure for 24 hours, whatever the goal is? They discuss that goal for discharge and, you know, and make sure everybody's in agreement. It's really valuable to the parents, to the nurses, make sure everybody's on the same page, right? But I think it's definitely important for the parent to feel that they're being listened to, right? They do know their child best. So that is, you know, that's like one of the big cardinal rules, you know, is always listen to the parents. So then thinking about critical thinking. So using all that data, right? So I love how you guys were talking about what you would assess, because it goes right back to assessment. I would be assessing, you know, why was the child acting that way with, you know, sucking on the washcloth? What were the signs of dehydration? Critically thinking and then reporting that to the doctor. So I like how, you know, you guys really honed in on what you needed to fix with that. Listening to the parent, advocating for the child. Anything else with the errors that were made in the Josie King case, other nursing errors, other errors in the, so how was the hospital negligent? We can look at the errors that were made that day, right? Or days leading up to her coding and her death. But then how could the family come back and say the hospital was negligent?
Because they weren't listening to the patient's rights. They weren't advocating. The mother said no narcotics, and she stated that, and they still gave the narcotics anyway. And then also just the communication from one nurse to another, that's on them. And unfortunately, the hospital is responsible if that does not take place.
Good. Yes, the hospital is responsible for the hiring of those nurses and the practice that's, you know, taken place on their units. Yes. But then also, how did they have, what processes did they have in place? So remember what came out of this and what's being implemented in hospitals nationwide is some way for family members, patients to be able to bypass nurses and physicians. And if they have concerns about a change in their status, that they can have a direct line to like a rapid response team or some kind of reporting system, so they can call and say, I'm concerned about my loved one. They're more confused, or they haven't been able to control their temperatures or something. And they could have a outside person come in, either, a director or charge nurse or supervisor on for that shift, come in, a patient relations person come in and address their concerns and look at those changes in that patient. So, we really focused how we approach patient status differently. We look now at you have to identify things much sooner than when they code. So how do you have those hospital processes in place? How do you have, communication for rapid response teams or PIT crews? And this is still evolving, because just this week on pediatrics in our clinical, they have this new thing called PEWS, PEWS. Not like Pepe Le Pew, the skunk or anything. It's PE. So it's, or Muse, I'm sorry, it's Muse. It's, and what does it stand for? Pews, Muse, it's PEWS, Pediatric Emergency Warning System. So every shift, the nurse, when she goes to do her assessment, she's looking at the changes in the vital signs and different parameters. And if there's significant changes in any of these metrics, it gives us a PEWS scoring, and it's an early warning system. And then based on that score, so like skin risk score, like pain scoring, and other, objective, right, measurement tools that we put in place. Fall risk scoring is another one, right? That then, connects to releasing standard orders based on that score. So if it's venous thromboembolism scoring, their VTE risk, then they'll be ordered heparin or warfarin or other measures, SCDs on their legs to prevent deep vein thrombosis. So that's where we have that involvement of the informatics. So if organizations haven't put standard, evidence-based practice tools in place to use their computers to do this kind of scoring and things, then if they don't have a way of that family calling and getting a supervisor to come in and look at that child, then the hospital could be liable, right? So that's why we need to be responding. So we have our the metrics that like Joint Commission puts out, right? So that every patient that comes in, we're going ahead and doing, for example, suicide precaution, right? Are they at suicide risk? So we're doing that depression screening on all patients that are admitted, and and making sure that we're not missing somebody who's suicidal, for example. So all of those kind of measures that are put in place, right? So do you feel like the nurses were biased toward the mother?
Not unreasonable to think that they were, like, at least annoyed by her, I mean, you got to remember, this whole story is being told by her perspective. Right. And in her hindsight, it's human nature to say, I didn't do anything wrong. I tried everything I could to save my kid. I'm not saying she didn't. I'm just saying that's, of course, going to be her perspective, which is why you have to make sure you document interactions and things like that to protect yourself from hindsight, like Monday morning quarterbacks.
Yes. Yeah. Yeah, there wasn't a lot of detail on the initial injury of the child and how that happened, right? How she went into a hot bathtub and got burned. And but there was another substandard care here too. And what's interesting? Just between us, okay? Remember, what happens in nursing 125 stays in nursing 125, okay? So, because this is private information. So the other day, on Friday, the nurse in Pete's ICU came up to me and said, so what do you think about this? night shift was pushing the PCA button for the child because the doctor wrote to, you know, that the child actually had like bony malformations. She had polydactyly in her arms. And so she couldn't push her own button. And so the nurses were pushing it for her. And there were times during the night that then they had to go in there and stimulate her to get, because her respiratory rate was being depressed. Right? I know, right, Monique? You're shaking your head. No, right? I know. And that's what I said. I said, no, that's, you know, substandard practice. You can't do that. That's part of the PCA protocol, is that the patient's got to be awake enough to push their own button.
Then the doctor shouldn't have wrote for a PCA pump, period.
Right?
That's...
Right?
Oh.
So guess what? The critical thinking, right? Then what does the nurse do? Notifies pharmacy, right? Calls the physician and says, we can't do this. I know you wrote it and the nurses were doing it last night, but you know what? We're going to change this. We're not going to do PCA mode. We can do a basal rate. So that's what they did, is then they gave her a basal drip, right? And they just did the PCA that way, where they just did a low dose of continuous morphine and didn't do PCA. And then and by that time, you know, she was getting better and they could, but yeah, so this does happen. So making sure that if there's protocols in your organization, if there's evidence-based practice out there on how to use patient-controlled analgesia, right? Don't change that practice and do something substandard that's going to have a negative outcome on your patient and put you at risk in that liability, right? How did that play a role in how much narcotic that patient was getting that then led to everything else that happened, okay? So, yeah, so just some of the little details of the case that we can kind of pick up on and glean. But really the takeaway is listen to the parent, right? Advocate for the patient, assess carefully, look for changes in your patient. And, okay, and I heard some things from you students too, saying, if I were there, I think I would, you know, there's times that you'll feel unsure of what you're seeing and what you should do. You're going to be inexperienced, right? Or maybe you feel like you question something to the doctor and they say, oh, well, that's okay. No, she's all right. You know, just tell the mother, we'll go and we'll check on her later or whatever, right? And you're not sure. What do you do? As a new graduate, you're out there working. What are you going to do in that situation, Sydney?
Can you repeat the question?
Yes. Okay. You're a new grad. You're working on a floor. You're in this situation where you feel like something's wrong, but you're not sure what it is, and you don't feel comfortable. You go to the doctor. He says everything's all right, but you don't know what to do next. So doctor's saying, don't worry about it. Maybe another nurse is saying, don't worry about it, but you still are kind of questioning things.
I mean, you're responsible for your own license. So at the end of the day, like, you should go to like either your superior or like, obviously your charge nurse would probably be the best bet, especially
Right.
if another nurse doesn't agree with you.
So what's that called? Using your
chain of command?
Yes, thank you. Exactly. Right. So remember, that's the process out there in those units, right? Use your chain of command, follow it up, right? Until you get resolution and you know that your patient's being cared for. So that's how you provide safe care, so that you're safe and you're not sorry. Okay. Okay. So any other insights, things we didn't discuss or talk about that, and hopefully you take some notes, right, on things that you're going to remember now for the rest of your life, so that you're always going to be safe and not have anything like this happen to you. Okay. If anybody needs to go ahead and get a quick drink or a bathroom break, let's go ahead and we'll take a break and we'll come back at 3, okay, or 3:01, I guess, right?
Hey, Miss Erickson, I just wanted to let you know that my name,
Yes.
was actually my girlfriend's name on here.
Yes, I know, I saw that, but now I see your name, Brett.
Yeah, I got it changed. I noticed after.
Yeah, I let you in. Yeah, I asked, I think it was Nathan that knew that was you.
Oh, gotcha. All right, thank you. I
I
appreciate
verified who you were before I let you in.
Okay, yeah, just wanted to let you know. Thank you.
Thank you. Hi, Sarah, did you have a question or?
Yeah, I did. So I just wanted to see if we could maybe go over the discussion board, kind kind of like the rubric. So do we do resources or not for responses and stuff like that?
Mm-hmm. So did you want to talk after privately? I don't know if there's anybody else that's listening right now. So I don't really want to discuss your particular grade. Was it a question about your grade?
No, I just wanted to know, so do you expect references with the actual initial post?
Well, like for this, if I felt like it was prudent, like if they were saying stuff that you wouldn't necessarily know as a new grad, as a novice student, I kind of made a comment on that. I kind of looked at overall what they were saying, and if that was kind of something they could just common knowledge say, or if it was something that would have been strengthened by then citing a source.
Okay, and then would the same go for the peer responses?
Yeah. Yep, same
Okay.
go for that too, because same kind of thing. If you're making comments about stuff that really isn't something you would necessarily have knowledge for, then really you should back up what you're saying with the source.
Okay. But it's not a part of the rubric to actually have to cite a source,
Well,
right?
it said on there to cite a source if applicable. So that would be if it's applicable, right? Is how I kind of looked at that. But I felt like overall, I didn't like take off 10 points for that or anything. You know, if anything, if I felt like, okay, really they should have had a source to defend, to kind of support that, I'd take off a couple points.
Okay.
Just kind of in general.
Okay, thank you.
Yeah, thank you.
Mm-hmm.
Okay, got one more minute. I've got 3 o'clock straight up. Nathan, what does it say on the banner above the window behind? Is that a window or is that a board, a write-on board behind you?
It's a closet door. It's just it says fire rescue. It's off the side of one of our old trucks.
Cool. Okay. I can make it out now.
The light's kind of weird in here, but yeah.
Uh-huh. So what kind of fire rescue did you do?
Did EMS for about
Firefighter?
15 years, and then I've been a volunteer firefighter for about 8 years. Yeah.
Do you ever fight the forest fires or
No, I don't
more
really like
rural
high-speed
residential?
landscaping. It's too much work.
Right?
Yeah.
I think it's so dangerous.
Yeah,
I don't know how they can do it.
I've done it a little bit, and I've trained to do it, but I don't go out and do it. Like, those guys are crazy.
Let alone the heat, just the heat aspect.
Yeah, I'll stick to burning buildings. I don't want to have to hike 20 miles to go fight a fire, you know?
I don't blame you. Okay, is everybody back? I don't see Monique yet, but there you are. It's like you heard me or something. Okay, hello everybody, welcome back. I hope you had a nice little quick break. Okay, I don't see Trevor yet. Are you there, Trevor? And Jess? Okay, everybody's populating, cool.
I was sitting here staring at the screen. I'm like, oh yeah, I'm back. And then I was like, yeah, my camera's not on.
Wow. So Madison, your husband is a firefighter, huh? House fire? Wow.
Mm-hmm. Yeah, he just works with TFD. He's not like a hot shot.
Brave people. Okay, so let's talk about cultural diversity and culture, okay? So cultural diversity is defined as that coexistence of different ethnic, biological, sex, racial, and socioeconomic groups within one social unit. So you can have people of varying religion, language, physical size, sexual orientation, age, disability, occupation status, and geographic location. Culture is defined as our shared system of beliefs and values and behavioral expectations that provides social structure for daily living. So we talk about like culture at school, right? Culture, work culture. I think it was really interesting, Robert, you were talking about how you as a lab, you know, were you like the head director or manager in the lab at University Medical Center?
Like the supervisor of the setup tech area.
And I just really kind of saw how you were, you know, describing the work culture that you expected there, and having that, you know, high level of care, and so having, you know, these different aspects of culture, right? These shared thoughts and beliefs and purpose for, you know, we have that in school here, right? We have that shared culture. Oh, your computer is frozen, Tom? Okay, hopefully I'll watch for him. You guys let me know if you see Tom in the waiting lobby or anything. So, you know, whether people are in a culture, maybe they have hearing disability, right? So if they're sign language, you know, they kind of have their own culture. People who are refugees from another country come and they kind of form subculture groups where they support each other. So they have their customs and their beliefs and their values, whether it's religious or ethnic or racial, right? And it's how they identify themselves as a group or a person. So there's a difference between ethnicity and race, right? Race is based more on the color of skin. Skin pigmentation, body stature, facial features, hair texture are all part of race. Where ethnicity is more like the country home, their home origin where they identify with, that common heritage, that sense of identification with a collective cultural group. So you just can't, like if somebody is Hispanic, that's their race, but then what's their ethnicity? Are they Mexican? Are they Spanish? Are they Puerto Rican? What ethnic group do they identify with? So that culture and those social beliefs and patterns include language and dialect, right? Religious practices, literature, folklore, music, political interests. It definitely impacts their beliefs regarding health practices. And that's where, as nurses, we need to know. So things that can inhibit your cultural sensitivity. And I think there's a self-awareness test in the book that's interesting to look at, because I think we all have some area that we're probably biased in. If we thought that we're, if we think that we're not, that just lends itself to being more true then, that we probably do have biases. So stereotyping is when you assume like, and I'm not going to say any of these because they're these negative stereotypes that, like certain people of a certain, race buy a certain vehicle of car or something, like they like this type of dog or they always do, right? Or whatever it is. So if you have these thoughts about a certain culture, and hey, Tom's getting back in. Welcome back, Tom. Sorry your computer froze. So, those negative stereotypes that, old people start to get slow and, they develop Alzheimer's, right? That's a stereotype. Not all old people get mentally cloudy, right? Or have Alzheimer's or, or have hearing loss. Going into somebody's room because they're older and raising your voice and yelling at them without assessing if they have hearing loss would be a stereotype. So many of us aren't even aware of our own personal biases and assumptions about people that we make that influence our ability to create respectful, trusting relationships, right? When we are interested in somebody's beliefs and their culture, then, that's when we can develop that rapport with that person. And that's one of the best parts of nursing, is being able to be involved with different people and learning from their life experiences and how that can just widen your whole view of the world, right? You go from room to room and every person is different. And that's really kind of the takeaway about assessing somebody's cultural needs and their beliefs, is that each person has their own views on life and their way that they view health beliefs, the way that they, their diet and religious practices and things, whether they like to take a bath in the morning or the evening or those kind of practices, everybody's individual. So when we impose our beliefs on somebody else, that's cultural imposition. Okay, so somebody who has maybe their Middle Eastern Indian or have a culture where they believe it's immodest for a male nurse to come in and take care of a woman or catheterize a woman, right? So they're requesting female caregivers. And we say, sorry, but you're here in America, so you're going to get the nurse that you're going to get. And if it's a male nurse, then a male nurse is going to take care of your wife. And, that's imposing our standards on them, right? We don't do that. We want to provide culturally competent care to somebody. We want to, include their culture into their plan of care. Cultural blindness is when we don't even see it or we ignore the differences, right? Maybe they are requesting a priest, but, I'll get to that when I have time or whatever. And we just blow it off, right? We're going to ignore that that's really important to our patient, that they wanted to pray before they went to surgery. Or we don't even see that the person's not eating because they're not getting food that is, part of, they're getting pork on their tray when, they don't eat pork. So, or, they're requesting a kosher meal and we don't even think about, that that's why they're not eating. So we can observe this within our healthcare system. especially in regard to non-traditional methods of care. And it's a shame that Esme is absent today because, you know, she had a specific experience with this where she was, as a child, put in that role of interpreting for her family, when evidence indicates that a lot of times family members, that's very disrespectful to have a child interpreting for a parent when you're talking about that parent's healthcare status. You know, that's something that they don't want to burden their child with, and then you're using the child as an interpreter. I think that was really, you know, another example of substandard care in terms of providing culturally competent care. Margaret Langinger is the nurse theorist who developed this transcultural assessment of people. And so she's cited in chapter 5 in her research. So she's the big nurse theorist who did study after study on how we can do cultural needs assessment and incorporate cultural competent care in our practice. So other factors, ethnocentrism, when we believe that our ideas and beliefs, you know, this whole thing of everybody who comes to the United States should learn to speak English, for example, right? When we, you know, that would not be culturally sensitive, right? I mean, that might be your own belief, but to believe that, you know, that's superior, and that when somebody comes into your organization, they don't speak English, that you don't have that obligation to provide education to them in a language they can understand. Okay, that organizations, Joint Commission, everybody identifies that speaking to a patient and doing informed patient consent has to be done in the language that they can understand. Otherwise, you're not getting informed consent, and you're not providing patient-centered care. So some of those beliefs that people might have don't fly when it comes to healthcare. So, you know, healthcare professionals assume that they have the right to make choices and decisions for patients. You don't look at, you know, that autonomy for your patient, that self-determination theory, right? That they have a right to make their own decisions. So if they decide that they're not going to go ahead with chemo, for example, and you're like, why wouldn't they do that? You know, or withdrawing life support, whatever it is, right? So not assuming that you have the ability to make their own decisions, if it's, you know, whether they should take pain medicine or not, right? That is the patient's decision. So cultural conflict occurs when people become aware of those cultural differences, they feel threatened, and they respond by ridiculing the beliefs and traditions of others to make themselves feel more secure about their own values. An example of this, so there's a well-known book in healthcare, and a lot of people who take courses on, you know, cultural competence and that, there's this book out there by Anne Fadiman. She is a reporter who went in and did a lot of investigation into this Hmong family. So the Hmong people, or I think it's just Hmong people. Does anybody remember the Clint Eastwood movie Gran Torino? It was out a while ago, right? Excellent movie where he had kind of that, wasn't that a great example of cultural conflict? Like he's looking at these people and across the street, and they don't take care of their property, and, you know, a whole different culture, a whole different food, very extended family. But the history, what this group of people, this culture, they helped during, now I'm trying to remember the war, and they were in the hills, and they helped the United States military defeat the enemy, and then they were allowed to come over as refugees, and they were promised, you know, benefits and services here as reward for this. They were great heroes during, I want to say, during World War II, but I don't know that it was that far. It might have been the Vietnam War. Obviously, it's been a while since I've read the book. But in this book, this little girl who's on the cover, she has a seizure disorder. And according to their beliefs, they believe that, you know, she's been chosen, that the spirit catches you and you fall down, that she's actually like a gifted child, and she has this higher status in her family. And so when they take her to this California clinic, you know, they don't want to give her the phenobarb because she becomes very sleepy and listless from the phenobarb. They don't like how she's acting, and so they're not, you know, adherent to the medication. Well, you know, so CPS gets involved. She gets removed from the family, and guess what? She gets neglected in the foster family that she's placed with. So, you know, that became this very sad kind of experience, and then she gets put back with her family who loves her and honors her, and she's the center of that whole family unit, right? But then she has this grand mal seizure, she has this horrible outcome, and you know, as this nurse gets more involved with the family and identifies, you know, their health beliefs and everything, you know, it becomes apparent like that they didn't like have the whole, when she just came to the clinic, they didn't understand the whole beliefs of the family and why they weren't giving the phenobarb and everything. So it just really brings to light the differences in cultures and how, you know, who are we to think that our culture is better? You know, why are we right and they're wrong? So thinking about the different physiologic variations, people of certain races, and your book identifies, you know, African American people and hypertension, and Native Americans and Alaskan Natives, heart disease, cirrhosis of the liver, diabetes, and fetal alcohol syndrome. African Americans, hypertension, stroke, sickle cell anemia, lactose intolerance, and keloid scarring. Asians, hypertension, cancer of the liver, lactose intolerance, and thalassemia. Hispanics are more prone to diabetes mellitus and lactose intolerance. And white people have a higher incidence of breast cancer, heart disease, hypertension, diabetes, and obesity. And Eastern European Jews, cystic fibrosis, Gaucher's disease, I don't know what that is, spinal muscular atrophy, and Tay-Sachs disease. Tay-Sachs disease is a big genetic hereditary disorder in Jewish people, so they are often referred to geneticists to see if they carry that gene. Also, reactions to pain. There are certain cultures where people might be very stoic and reserved, right? But they may report pain, but they don't show the signs of pain. And also in the Hispanic culture, people can be very flamboyant and expressive in expressing either grief. They might have like what's actually called these ataques, where they're very histrionic in their expressions and they cry out. And, you know, that can be unsettling to some people who aren't used to that, you know. And for example, Chinese, they don't really recognize mental illness. They look at, you know, there's this bias in that culture against mental illness, and they don't really, they look at more of the imbalances in life and things. So, and also the difference between gender roles, right? Whether, what is the role of women and men in that culture, who makes decisions, and expectations according to gender. Language is a huge area of cultural competence. So in most organizations, they have Seracom interpreter phones at the bedside, blue phone that's really easy. It's got two handsets to it. Nurse gets on one side, pushes some buttons, gets an interpreter somewhere in the world that speaks the patient's language, and they give you identification number that you document who the interpreter is, and they state that they're going to translate exactly what you say word for word to the patient, and then they introduce themselves to the parent or the patient, and you start your conversation back and forth. They do training with how to use these interpreters, and you know, you should be facing the patient and still communicating to the patient. And you know, nonverbal is a huge part of communication also. And also making sure that you're always using interpreters in the organization who have been tested and, you know, are providing medical interpretation correctly. So guidelines for how we can provide competent care for minorities is on this website with the Health and Human Services. But that's a huge area for liability with the hospital. And it amazes me how one wrong word and you can totally misunderstand what the patient's saying, what their questions are, and you can provide incompetent care if you're not addressing an issue. So it's really important when you're doing your assessment, right, of their communication. What language do they speak? How well does the patient speak and write English? Because you don't want to be providing discharge instructions in English if they don't understand English. Does the patient need an interpreter? What's nice about Epic is now we can choose other languages for printouts. So there's not every language though. It's still an issue. If they need an interpreter, you know, we need to get that interpreter available. Are family members or friends available? Although we're not wanting to use them as medical interpreters. Are the people the patient would not want to serve as an interpreter? So getting those people on the list too. How does the patient prefer to be addressed? What cultural values and beliefs of the patient, such as eye contact, personal space, social taboos, may change your techniques of communication and care? Remember touch? And people have different personal space expectations. Eye contact can be threatening, right? Sometimes talking fast. Sometimes certain cultures expect you to wait for a response. And it might be viewed as, you know, being inconsiderate if you're not waiting for, or, you know, is the man going to be the one that's going to be providing the communication? So how does the patient's nonverbal behavior affect the responses of the members of the healthcare team? What are the cultural characteristics of the patient communications with others? You know, a lot of organizations have policies not to cut hair, not to cut fingernails because of religious beliefs. Things like making sure if they have a saint pinned to the pillowcase, that we're not losing that or removing it. If certain cultures will use like red yarn or string on the wrist, or there might be other jewelry or, you know, religious symbols or things that are important to them. Is it important to them? Do they have like a medicine man in their community? Or I'm trying to remember the name of the woman who comes in the Hispanic population. You know, she's like the witch, you know, the good witch, right? The healing witch in the...
They're called curanderos.
Yeah, so,
That's
you
like
know,
a healing person.
yeah, incorporating those people into their plan of care. You know, do they want to come in and burn sage? You know, will your facility allow that? If prayer is going on, is there a way to allow for, you know, quiet and nobody to disturb them in the room? Do you, as the nurse, you know, what if the family invites you into that? You know, would you want to participate? Is it something you would feel comfortable doing? Now, don't feel like, you know, that imposition can go both ways too. It's okay as the professional nurse to say, you know, I respect, I support you, you know, but that's not my personal belief. So you know, I don't want to come in and not be a part of that ceremony, right? I respect your ceremony, but, you know, I don't feel comfortable participating in it because, you know, or is it something you're open to and you want to experience? So kind of be in touch with your own, like your own biases, or, you know, but just be true to your own self, right? And I think, you know, most patients would respect that. So don't feel like you have to be imposed on either. So, you know, also, how does, you know, culture affect healthcare? You know, we talked about the time and space, you know, the personal space, how we communicate, but, you know, what they eat. I've had families that keep food in the room and then they're not refrigerating it, right? So sometimes, you know, there are safety issues and we have to kind of say, okay, you're cooking fish in the bathroom with a wok, I mean, that's kind of not safe, right? You have to have, the medical, whoever checks off electronic equipment in the healthcare facility. I forget what department it is now, but
The biomed.
thank you. Yes, come in and check it off and say, yes, it's safe for them to use that or whatever. But so, some of these practices, you want to make sure that they're not starting a fire in the room or something. But or if they need a refrigerator in the room, if they're going to bring in their own food, family support, right? So we do want to allow the patient to have, food that they're used to eating, know how they're cooking food. So if we're teaching them diabetes education, we need to know the recipes and things so we can count carbs. It doesn't make sense for us to teach them and then have them go home and do a whole nother practice. So find out who's doing the cooking and that. Family support, incorporate those people, those godmothers and godfathers and aunts and uncles and extended family, whoever's going to be taking care of the patient that wants to be involved in learning their care and is positive support. Socioeconomic factors. Do they have access to health care and food and transportation? We have a huge health disparity in our nation with minority populations, refugee populations, people with disabilities. When a child is born with a disability, it almost 100% of the time throws that family into poverty. A lot of times it means a parent needs to quit their job and take care of the child. We do have the children's clinics here in Tucson. So a child with a CRS qualifying diagnosis can get free care. And that clinic does a really good job at coordinating care and kind of has a medical home model to support the whole family. But, families that have a child with who's disabled, have a lot of financial strains on them. So 15% of our US population in 2014 had an income below poverty threshold. Okay. So we look at our homeless population, we look at the needs of the LBGT community and biases against them, health disparities against single women, older adults, also all those populations that are vulnerable. Okay, anybody else have any comments or insights into different cultures and cultural needs, things that you've seen in the hospital or in other care settings and personal experience?
I think you said all of them too. It's really important too when a patient, well, I think you said something about it when they die, because every culture has like different things that they like to do or like to be in the room when you like have to get ready to bag the body or certain things like that.
Right. I remember years ago, there was a girl, she was a teenage girl who was hiking in Sabino Canyon with her Girl Scout troop, and she actually drowned in a small amount of water that was running in the stream there. She fell somehow, and I don't know how they didn't recognize that she was drowning, but she ended up dying in our ICU, and her mother was grieving very loudly and everything. But with her, whatever her belief was, I just remember that when we were preparing the body and putting her in the body bag, they had a red paper circle, and the mother had requested that we kept it under her body at all times because there was something, a belief about it, like directing the soul or something like that, that she just, that was the big request, was that this paper red circle was under the body at all times. So, just acknowledging, making sure that that was our priority then also, to make sure that those mothers' wishes were carried out and that we were practicing that for her. So, and then I got in my car at the end of my shift and as I turned on my car, Dust in the Wind came on the radio right from the very beginning, right? Dun, 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 dun. And it's just one of those, you know, I close my eyes, right? And I was like, just the tears just came, right? After a shift like that. It was like weird. It was just weird that that song came on right like that. But yeah, so when we're dealing with all these different cultures and just acknowledging the differences that we have as human beings, but also the similarities, right? That shared human experience of each of us walking our own path and having our own life experiences and beliefs, right? We need to practice that cultural humility, you know, put our feet in the other person's shoes. So, you know, the golden rule doesn't cut it when it comes to cultural competence. You're not doing to others as you would have them do unto you, right? You're doing as they want you to do unto them. So you're putting yourself in their shoes and caring for them like they want to be cared for. That element of cultural competence. You're developing that awareness of one's own existence and sensations and thoughts in an environment to prevent them from having this undue influence on those from other backgrounds, right? Demonstrating knowledge and understanding of their culture, health-related needs, cultural specific meanings of health and illness to them, accepting and respecting cultural differences in a manner that facilitates their abilities to make decisions to meet their needs and beliefs, and not assuming that healthcare providers' beliefs and values are the same as the patient's. We want to know what they believe. We want to know what alternative medicine they practice, what supplements they take, anything that we need to know to take the very best care of them. Resisting judgmental attitudes that, you know, we would never, you know, like joke in the nurse's station about them being weird or something like that, right? Different is not as good. That's not true, right? Different opens our minds to new possibilities and ways of experiencing our world. Being open to and comfortable with cultural encounters, accepting responsibility for one's own education and cultural competence by attending conferences, reading professional literature, and observing cultural practices. It's always being open to new things in life, new ways of looking at things. So I like, this is a out of image from your book. You know, this is out of Langinger's research, kind of that continuum of whether you're being conscious or unconscious and whether you're practicing competence or incompetence. And then, you know, looking at our whole world and the community and family and the individual person, because we don't want to have those stereotypes, right? Just because somebody's from a certain background doesn't mean that they, you know, just because somebody identifies as being Catholic doesn't mean they don't practice birth control, for example, right? They'll have their own personal beliefs. So you don't, you know, whatever it is, you're still assessing that person as the individual. So, time for some questions, ha ha ha. Where should I begin? Okay, Tawny, a nurse. We like select all, who likes select all apply questions, right? Oh, we love them, hey. You got what, a 1 in 25 chance, right? Or more of getting wrong. Your odds are not in your favor. So when you approach a select all that apply question, look at it as 5 true and false questions, right? You got to stop and go, okay, read the question. A, is that true or false? Read the question. B, is it true or false? So just take your time with it. Okay, so Tani, this is all you, okay? A nurse is caring for patients of diverse cultures in a community healthcare facility. Which characteristics of cultural diversity that exist in the United States should the nurse consider when planning cultural competent care? I'll get the answers. Has the United States become less inclusive of same-sex couples? No, that's not true.
Cultural diversity is
What's that?
I was just reading the
okay.
Answers. People may be members of multiple cultural groups at one time. C.
Okay. What else? Select all and apply. Is that the only one?
No. Maybe F. I don't know, not the mainly constant.
Okay. So it's D, E, and F. A person may be a member of multiple cultural, ethnic, and racial groups at one time. Culture guides what is acceptable behavior for people in a specific group. Cultural practices and beliefs may evolve over time, but they mainly remain constant as long as they satisfy a group's needs. And the United States have become more inclusive of same-sex couples. The definition of cultural diversity includes, but is not limited to, people of varying cultures, racial and ethnic origin, religion, language, physical size, biological sex, sexual orientation, age, disability, socioeconomic status, occupational status, and geographic location. And cultural diversity, including culture, ethnicity, and race, is an integral component of both health and illness. I feel like we need to come up for an acronym with that so we remember all those things that are included, all those components of cultural diversity. So whoever comes up with the song first, share it with the others. I think the answers are in the comments, right? Are the answers down in the speaker notes? Okay, number 2. Okay, Nathan. In order to provide culturally competent care, nurses must be alert to factors inhibiting sensitivity to diversity in the healthcare system. Which nursing actions are examples of cultural imposition? Select the all that applies. So remember what cultural imposition means.
So A obviously would be.
A and what?
A would be, B would be.
So treating everybody the same, how is that imposing anything on them though? Remember, we have other definitions to consider though.
Cultural imposition?
Yeah.
Imposing my culture on them?
Yeah.
Or am I reading that wrong?
Specifically that, yeah.
Well, by telling them they have to bathe daily, they have to eat this food I tell them, that's me imposing.
Correct. So
culture.
A, yeah, yeah,
So
A's true. Not B
yeah.
though.
All right. Probably C also.
I think C they're saying, so C is something else also.
Okay. Well then I don't know, I say F.
I'm with you, Nate. These are hard.
I know, I hate this question.
You hate this question?
I hate these type of questions.
Nate, there's multiple. So one of them is
I gave
cultural
multiple answers,
blindness.
but I was wrong multiple times. So.
No, you're fine. There's cultural blindness in here too. So there's other answers that apply to what we're talking about.
Right.
But she's looking for just imposing your culture on them. So there's only 2 answers that I see.
Right, but what we like, yeah. Which ones do you see?
So A, like you said, and then delta.
Yeah, and D, A and D, right? And as in delta. I like the. Yep, correct. So B is blindness, right? Because you're not seeing the differences. You're treating them all the same, whether or not they come from a different culture. So A and D. So cultural imposition occurs when a hospital nurse tells a nurse's aide that patients should not be given a choice whether or not to shower or bathe daily, and when a Catholic nurse insists that a patient with diagnosed with terminal bladder cancer sees the chaplain in residence. Cultural blindness occurs when a nurse treats all the patients the same, whether or not they come from a different culture. Cultural conflict occurs when a nurse ridicules a patient by telling another nurse that Jewish diet restrictions are just a way for Jewish patients to get a special tray of their favorite foods. When a nurse refuses to respect an older adult's ability to speak for himself or herself, or if the nurse refuses to treat a patient based on the patient's sexual orientation, the nurse is engaging in stereotyping. Okay. So those are like NCLEX style questions. And you're right, it is kind of difficult to discern how the context of how they want you to read that question and right and kind of take it. So they do kind of make it difficult. Okay, so a nurse caring for culturally diverse patients in a healthcare provider's office. And I got my screen sharing right in the way. What does it say? Patients of certain cultures are more prone to specific diseases. States that the general population, which patient would the nurse screen for diabetes based on the patient's race? Okay, Madison, Somerville.
Well, I have your PowerPoint pulled up so I can see the answers, but it's A, B, and F.
So go ahead and read the rationale for me then too.
So it's kind of small. Hold on. So it says Native Americans, Alaska Natives, Hispanics, and whites are most prone to developing diabetes. African Americans are prone to hypertension, stroke, sickle cell anemia, lactose intolerance, and keloids. Asians are prone to hypertension, liver cancer, and lactose intolerance.
Thank you.
Mm-hmm.
Again, it's one of those things like we were talking about patient safety, right? How would we remember all of this? So you get somebody from a certain culture, right? And you look it up and you look at that culture. And then when you go in and you're assessing your patient, you can say things like, okay, so I'm a little bit familiar with your culture and your back, you know, and your, so do you, you know, what are your practices? And, you know, and then you go from there, right? So values and ethics and advocacy, doing the right thing, right? So we talked about this with, in terms of Josie King, right? Values are beliefs about the worth of something and what matters, right? Where your treasure is, there your heart is, right? That act as a standard to guiding your behavior. So you're not born with values, right? You gain values probably from your parents first, right? From teachers, from fellow students. Anytime that somebody's modeling a certain behavior or, you know, something you can identify with that you value, that's going to, you know, form an influence on you from the environment, from family and culture. So we have this values clarification process that, you know, which is kind of this process that we all go through in determining our values and our value system. We kind of choose these values, we prize and kind of treasure, we act on our values. So, you know, coming to class every week, you know, you're valuing your education. You know, you value your own your trustworthiness. So you're going to behave in a way that is above reproach. You don't want anybody questioning, you know, your integrity as a student. So you're going to make sure you want to be professional and you value that. So you're going to communicate in a professional way in emails and, you know, notify, you know, follow policies. And, you know, isn't it interesting how your student handbook does kind of define, you know, our culture and behavior that's expected out of students in our program, but then you also determine whether that's something that you value through your behavior and, you know, and how you demonstrate that. So how you act. So I heard a lot of these words in how you were talking about how, you know, the mother's right to refuse, you know, looking at the autonomy there, looking at, you know, altruism, you know, what do we value, that human dignity, integrity of the nurses, and, you know, doing what they say they're going to do. Social justice is kind of becoming more politicized right now, isn't it? So, you know, do we believe in the right for everyone in our society to reach their full potential? Do we believe in, you know, healthcare being a right for every human person? They should be able to go and get healthcare, that's a human right? Or is it a market justice? Is it something that, is it a commodity that people pay for? You know, that they should have to work and pay in and get and have health insurance to receive healthcare. Who should get vaccines? You know, those who are more vulnerable, should they be free because having a vaccine out there is going to benefit the general public, right? So how do we view that in terms of, you know, our professional values too? So just some questions. I'm not, you know, saying one way or the other. But we can also debate that further when we talk about immunizations, right? Because that's going to, so ethics is, you know, kind of that principle. Do we know the difference between right and wrong? Especially when it comes to end of life. Where's that quality of life versus those quantity, you know, days? So, you know, it's virtue and vice, good and evil, as they relate to conduct and human flourishing. Nursing ethics, that kind of subset of bioethics, that formal study of these ethical issues that arise in the practice of nursing. You know, who should get the kidney transplant? The person who is still drinking, who can't kick their addiction, or, you know, somebody who is demonstrating that they're ready, you know, has a match, has a family member who's willing to give the kidney, you know, so, you know, sometimes we have to make these ethical calls. You know, we were looking just recently in the United States at looking at who's going to get the ventilator, right? Or if we can Y in and share ventilators, those kind of things that fortunately it didn't come to. Moral distress occurs when you know the right thing to do, but either personal or institutional factors make it difficult to follow the correct course of action. Okay, and there's a great, I think I have the next slide. Do I have it in here? Yes, this, you know, what you should do if you're ever faced with that ethical, that moral distress kind of thing, you know, ask, why am I feeling this distress? What is it about it? Become aware that that moral distress is present. You know, is it because there's just not enough time in the day and you always feel like you're walking out of that place drained emotionally because you gave everything you could and it just wasn't enough, right? So affirm your distress, commit yourself to take care of yourself. You know, is the family making a decision that you feel is wrong? You know, I think it was interesting. One of our recent graduates, well, from a few years out or so, I was talking to him. He's working at Planned Parenthood. You know, he was talking about some of these issues and people kind of looking at him as being the baby killer, right? So, you know, kind of that could be a situation for a lot of people that might, you know, cause some moral distress. But also looking at that he found himself in a situation where he was able to address a human trafficking issue and how, you know, how there were a lot of really good services that he could provide also. So it was an interesting discussion. And actually, you know, it's kind of interesting some of the professional experiences that he's been able to have because of the role he's playing in that place. So, you know, identifying sources of your distress, personal environment, determining the severity of your distress, contemplate your readiness to act, looking for that support in your environment, okay? So implement strategies to initiate changes that you desire. If there's things that you can't accept, then change it, right? Make that place, either change it in the place where you're at or move to another, you know, quit that job and go someplace else. So the goal is that you preserve your integrity and authenticity. So looking at these 4 A's to resolve moral distress: ask, affirm, assess, act. And it's kind of that ongoing process with yourself, right? And what you want to have is that creation of a healthy environment where critical care nurses make their optimal contributions to patients and families. So this was developed in a critical care setting. Okay. So different virtues of that nurse, right? Competence. We talked about being that competent nurse. You know the care, you know the meds, you know the information, and then also having that caring and competence. Subordination of self-interest to the patient interest, right? Putting your own beliefs and your own culture and that kind of those, you know, you're not going to impose your culture, you're not going to have conflict, you're going to be open-minded and accept the patient's beliefs, put yourself in their shoes and how they want to be taken care of, that self-effacement, and you're going to be trustworthy and conscientious and do what you say you're going to do. You're going to be back in an hour to check on that patient, you're going to follow through and you're going to be there. Conscientiousness, intelligence, lifelong learner, right? You're up on current practices, you're incorporating evidence-based practice, practical wisdom, humility, courage, and integrity. And courage really is putting your own, you know, that your own fears aside and focusing on the patient and why you're there and meeting their needs. So we also have, you know, governing bodies over us that have, you know, given us definitions of these code of ethics, not doing harm, right? What does it mean to provide cultural competence? You know, identifying the language that the patient speaks, making sure that they understand and they have the information to make informed consent. We have the American Nurses Association, Canada Student Nurses Association. So different ethical problems, you know, when a physician wants to kind of be that father figure, the paternalism, you know, they know what's best for the patient. They're going to do this course without really. So another patient example of this, One of the nurses was out in the hallway with a mother of a teenager who was a minor, right? And she was saying, you know, I'm having a really hard time making this decision about what I should do with my son's care. The doctors, this teenager had ulcerative colitis, and they were looking at doing a bowel resection or waiting and trying, you know, a course of medications and seeing if it would resolve, or if they, you know, he was continuing to have bleeding and losing blood, and they thought it might be better to just do the bowel resection. And so the mother was out kind of morally, you know, agonizing over whether she should sign a consent and go ahead with surgery or not, when the nurse said to her, well, have you talked to your son about this? You know, what does he think? And the mother looked at her and said, you're right. I should go in and talk to him. I don't know. You know, I haven't talked to him about it. And so, she was like, oh my, you know, I should go in and talk to my son about this. So she went and talked to him, and guess what? You know, he knows how he feels, right? He still felt strong enough to give the medicine some more time to see if he would respond and if it would stop the bleeding and stop this, you know, acute episode of ulcerative colitis. And he didn't want to do the surgery because once he loses that bowel, you know, you can't get that back. So he wanted to be involved in his own decision making. So the nurse advocated for the mother not to be in that paternalistic role. Okay, so that's an example of that I just recently saw in the healthcare setting. It's a beautiful moment. I call those little come to Jesus moments where you're outside and you're having that rapport with that parent, and you can't talk like that to a parent unless you have that rapport first, right? Unless you have that you know that person, you know their beliefs, you know the way that they communicate, and you have that trust established. So, you know, deception, if you're telling them you're doing something that you're not, privacy, social media, right? HIPAA, you got to maintain their privacy. That's the person's dignity, right? Confidentiality. And if we have scarce allocation of resources, informed consent, valid consent, or refusal, right? Like that mother refusing that narcotic. We all identified right away that nurse should have stopped and not given that last dose of medication. Conflict concerning new technologies, unprofessional, incompetent, unethical, or illegal physician or nurse practice, short staffing issues. A lot of you questioned, I wonder what staffing was like on that day. You know, did that play a role in the nurses not coming in and helping out? And beginning and end of life issues like you talked about, Monique, you know, incorporating their culture and beliefs into end of life. And if you're not maintaining that for that family member, that's an ethical problem, especially, you know, withdrawing care, fluids, food, that kind of stuff, those kind of decisions. So nursing care for patients in the intensive care unit develops values from experience to form a personal code of ethics. Which statements best describe this process? Morgan Stump. So the process of developing this personal code of ethics. Are you born with values?
I think that you, not born with values, but I think that you're born with a sense of what's right and wrong based off of your upbringing, kind of type thing.
On. Well, according to our textbook, it says we're not really
Say
born
hi,
with
Granny.
What's that?
Sorry. Yeah, and I think that it has a lot to do with your upbringing, but I definitely think that I know a lot of people who have grown up in a house that are not necessarily like good homes, but they still have a sense of what's right and what's wrong.
That's right. They got that training from somewhere, though. They picked that up in some observation in the world, right? Whether it was from Mr. Rogers or a teacher or somebody, somewhere, some belief. Whether it was an innate
morality.
Belief. What's that?
Relative morality.
There you go. Their own relationship with their higher being, huh? I guess we could delve into this deeper, couldn't we? or we could go with what the book says. So, yeah, so according to the book, people aren't born with values. But, okay, so B? Are you still there, Morgan?
I am, yes.
Okay,
sorry. Yes, so I'm sorry. Understanding which statements best describe this process. So, standards to guide. I would say yes, B.
Uh-huh.
I would say C, but not just your values, but the patient's values. And then D, definitely, because depending on who you are, you can view sickness differently.
Right.
Not E, and then should know their values influence patient care. F is kind of up in the air, I would say, because sometimes your values can, don't want to say benefit the patient. I would probably say no if we're talking just from the book. But from like a personal standpoint, sometimes you know that pulling the plug isn't right and that they're doing it really early. Like a patient might be 50 and they're pulling the plug and there's no real indication that this patient couldn't make it a couple more days or pull through, you know?
Right.
Like in that situation where you would want to at least talk to the either parents or the kids or whatever and be able to listen to them and their concerns, and then maybe not tell them what to do, but maybe like give them more information about what's going on, because that's tugging at your strings.
Exactly. If you have if there's a big conflict between your values and your practice, then you're going to have that moral distress, right? So your values have to kind of guide your actions. Yeah. So you're right. The answers are B, C, and D. Yep. Very good. So yeah, I like how you thought through each of those as a true and false. A nurse who's working in a hospital setting uses values clarification to help understand the values that motivate patient behavior. Which examples denote prizing in the process of value clarification? Trevor.
I knew this was coming, but I think I was kicked out of the Zoom when we were going over this. I'm not 100% too sure.
Okay, you want to phone a friend?
Yes. Don't worry, Chanel. I'm not going to call on you this time. Okay, we'll just go with Nicole Mendez.
Okay, Nicole.
I would say A, no, for sure no. Patient shows off new outfit that she was wearing after losing 20 pounds. Yes, I would say yes to that one. Not C, no to C. Maybe D, maybe not, probably not. Not E. An F, patient displaying his certificate for completing a marathon. I would want to say yes to that.
Yeah, I think the shows off and proudly displays kind of gives those two, you know, is what they're trying to say in those, is that denotes the prizing process. So it's B and F for that one. And a student nurse begins a clinical rotation in a long-term care facility and quickly realizes that certain residents have unmet needs. The student wants to advocate for these residents. Which statements accurately describe this concept? So how are you advocating? Okay, Tom Smith.
So A.
Mm-hmm.
C and D. And
so if you're advocating, are you making the good healthcare decisions for the patients and residents?
I guess it depends on the perspective. I mean, like, part of our advocacy is the conversations that happen behind closed doors and the things that are even brought to the patient's, awareness. So we have to make decisions based on what we know and take those choices to the patient.
Right, but we don't want to add that to that answer, so it's not D. So, but you were right about A and C. Did you say, you said A and C, right?
Yes.
And there's one more.
I'm gonna guess that F is the correct answer, but that's, yeah.
Right. You know, one thing I was thinking about today, what do you guys think about this idea? I was thinking about how, as nurses, would it be a prudent, like, or a good idea, okay, to start an initiative where we want to take protests off the streets? Like, how can we create a forum for people to express their beliefs and take action in a way that keeps us more safe during a pandemic? I mean, wouldn't that be like a nursing type of interest, like a public interest? It's like, I don't like to see these demonstrations then turn violent. I don't know. Maybe you guys think this is okay, you know? But I was wondering if there's a way. I was almost kind of, I had this thought like today. I thought, what is it about our political leaders that they're not coming to the people and saying, I hear you, I want you to, you know, write to me. Here's forums where we can meet and we can come up with solutions to issues and problems. I want to hear you, you know, instead of people having to march and be in each other's faces and, you know, and have these conflicts. I don't know. Maybe I'm, you know.
All of those things already exist.
Okay, right? But why, but how can we like facilitate it more as nurses or something, or maybe that's patient advocacy. I mean, you're right, it does, but does everybody know about it, or do they have the means to do it?
Or does it work?
Or does it work? So how can we organize and, you know, or how, so, I mean, anyway, whole nother discussion, but I felt like there was some kind of advocacy role as nurses that we could be looking at promoting safety in this current, you know, climate. But I don't know. It's just like, I'm just proposing a thought, okay? And it's a nonpartisan, it's just like wanting to think about overall health and wellness of people, right? And how people can feel heard, but yet be safe. So I don't know. I don't have answers. Like I said, it was just something I was kind of thinking about as a nurse today. Maybe because of some of these topics. Okay, so it's time for another break. Let's take a quick 10 minutes.
What's wrong? Please tell me the night is dying.
So Shelby, you're still in peds? You're at Banner?
Yes, I'm the med surg peds, yeah. I love it. I've been there for 3 years now and it's amazing.
Uh-huh. Very good. So I wonder if I know anybody over there now. Is Affy, but Affy, I think I know most of the nurses I know are in the ICU.
Yeah, Affy's in the ICU.
Carla Goodhart.
I don't know that name.
No, not Carla. Who else do I know? Oh, I'd have to think.
Yeah, we were in the PICU for about like 2 to 3 months because of COVID. Our ped census went down, and so we combined with the 6th floor during COVID. And so we basically are stationed, we were stationed out of the PICU floor, but we're receiving like the floor status patients. And so we did a lot up in the PICU and learned some of their techniques and things. So, because our Diamond Floor 5 was converted into a COVID floor. So
wow.
At one point, our 36 bed floor had 36 adult COVID patients on it. So
wow.
It was crazy. But luckily we were back on our floor and we were so excited to be home. I mean, not good for the kids, but we are back on our home unit.
Very good. Okay, so just real quick, I want to share another example. Has anybody seen the movie The Farewell? And that has this actress who I forget what her name is now. So share computer sound.
What's wrong, Dad? Please tell me. Your Nan is dying.
What is your name?
Know, so you can't say anything. The family thinks it's better not to tell her.
It's Nora.
How's that better?
Well, it's Nora from Robert Parent Queen.
When people get cancer, they die.
Aquafina.
That's it, yes, yes.
We'll have to go to China.
Wedding is an excuse so everyone can see her.
He's my only cousin. Did you think I should be there?
You can't hide your emotions. If you go, Nana will find out right away.
Really 呀？咋啦？咋不说话呢？今天人多齐呀，好久没这么聚了，奶奶就等着这一天呐。来，大口咬，哇！哈哈哈哈！
你觉得我们应该告诉奶奶吗？
太痛苦了吧？
如果她想说再见呢？
你告诉她就毁了她美好的心情，你说对吧？搭到她的肩膀上，你说我都怀疑我又不在，他俩在卧室能干啥呀？
Shouldn't we tell her? Isn't it wrong to lie?
It's a good lie. Most families in China would choose not to tell her.
你们说的啥呀？
她在英国学习，所以她会说英文。
结婚了吗？
妈。
She's dying. Can you be a little more sensitive?
What do you want from me? To scream and cry like you?
因为你把生命看成是个体的，这正是西方和东方的文化差异问题。东方人是把生命看作是集体的家庭。
I want to believe that's a good thing.
因为生活呀，不光是你去做什么，更是你如何去做。傻孩子。好多了，好多了，好多了，再来点气儿，再来点气儿。
So kind of the takeaway with that was of the movie was that, I guess spoiler alert, huh? She lives much longer than expected because of her positive beliefs, right? That they don't tell her that she's dying of cancer, so she doesn't assume that sick roll and die like she's expected to, right? So just kind of a difference of culture and belief there with the Asian, population. So, and you saw some other things in that too, with values and the passing on the generations, the respect for the elders, right? So we see some cultural examples there, right? Okay, so now what I want to do is break you up into your teams. Okay, so what we're going to do here, and what I want is I posted in the point, it talks, there's a cultural perspective, and it talks about what you do when you do a cultural assessment, okay, in terms of the language the person speaks, their diet, their how do they celebrate traditions, what do they do in terms of their activities of daily living and things. So review that cultural perspective, and then go to your assigned culture. Okay, so team 1, if you get assigned team 1 and you're in chat room 1, African American, you're going to kind of demonstrate what a bias would look like. So the nurses, there's going to be some bias being presented, and then the nurse is going to do this cultural assessment and advocate for the patient so that we're overcoming these biases. Navajo, you're going to have some cultural blindness being is the issue there. LGBT community imposition. So have you been in the point? Have you seen how when you go under the cultural perspective and you can look at these different cultures, it gives you kind of some general, you know, characteristics of that culture or that belief, or so that you can become more culturally competent. Okay, so we're going to develop a quick little role play. Team 4, you're going to be Mexicans and stereotyping. Team 5, homeless community and bias. So we think about the biases we have against the homeless community. Team 6, Iranians and blindness. Okay, or if you want to do cultural conflict or something else, feel free to change it up. I give you expressive artistic licensure. Okay, so have fun with this in your teams. I'm going to quickly break you out into your chat room. Have you done this before? Gone into a room?
I apologize. I have zero idea where the cultural aspect is in the point.
Okay, so when you
under
sign,
a book?
No, you sign into the point, you go to Lippincott Advisor. Okay? It's one of your choices in Lippincott Advisor. I'm going to be checking into the chat rooms, okay? So if you have any trouble, I'll be there. I also posted it in this week's Blackboard as with the instructions for this activity. So it is in there too. You can pull it up there.
So you know where you go.
Sorry, Monique, you're breaking up.
That one choice for the prep, it's right under. So I was telling you where the prep use is at. It's right below it. That choice right below it for Lippincott. Once you click on Lippincott, it's like down
under the advisor. Thank you so
much. Okay. Like I said, I'll be going around and checking on you. Okay. I'm going to create the rooms. We're going to take till, let's try to get this done by 4:35, and then we'll come back and we'll finish them up real quick. Maybe even 4:30. On your mark, get set, go. Go to your rooms. Hello, yes, so you're African Americans. So what I want you to do is like somebody be the role of like the patient, and then a family member, nurse, physician, right? And then delegate those out. Somebody can just be writing up stuff and taking notes. That's not, you know, participating in the actual, whoever doesn't want, like doing role plays can be in a different role of maybe taking notes for people. You might want to work into the case study, like if the person has hypertension, because we know, you know, like what are those things that African Americans are at risk for in terms of disease processes? Kind of work that into to remind everybody, right?
Could we like include like their spiritual beliefs too? Or like maybe like, not that everybody does that, but.
Yeah, but review the facts in the point to that culture, you know, so that we're not, yeah. We gotta be sensitive, right? Because we don't want to come across like we're actually promoting these biases, right? As we're developing the role play. Yeah. So do you
What exactly? So I'm looking at the Lippincott Advisor, and so I'm reading some of their beliefs and their practices. And you want us to like be biased with some of these, or?
So maybe there's somebody in the team that's biased. Maybe the physician is being biased and like telling the nurse something like, well, of course they're going to do this and do that or whatever, or, you know, I don't think it's right that that so many people are in the room. I want you to kick some of the people out. And then you have to say, no, family's really important. And, you know, we're you know, advocate for the family. As you're looking through that, kind of think about what, you know, could create, you know, what could be some of the biases that people would have. And then make sure that you're looking at, yeah, including their, you know, assessing their culture, ethnicity, community orientation, culture, values, beliefs, religious and spiritual beliefs and practices, communication and language. You know, what if it's, you know, certain people have different words that they use to describe pain, or, you know, how they feel about expressing pain. You know, maybe tough guys don't cry. So whether it's gender, or, and then specific health and illness concerns, activities of daily living, food, nutrition, dietary considerations, birth, postpartum beliefs and concerns, end of life concerns. So choose any of those that you're kind of assessing and incorporating into your plan of care. Okay?
Okay.
But don't get too picky. You don't have a lot of time, so you just kind of have to decide and go with it. And have fun.
We'll try.
It's this good opportunity to kind of work with each other and, you know, be creative.
Do the role play. So are we going back and forth, or are you just telling basically a situation?
Yep, so each of you decide a role, right? Pick one person to be the patient, be the nurse. You know, somebody's going to be acting out the kind of the role where they're the healthcare person who's being blind to whatever's going on. And then maybe you know, another person's going to be the healthcare worker that's going to kind of say, don't, you know, kind of basically, don't you see this? Don't you see this is important to your patient? They're like, no, I wasn't even aware that that was a concern for this population. Something like that. And in the meantime, you're teaching everybody else, you're giving them another example of this in practice. So just something real short. Maybe adding one of these things in there. Maybe it's a birth experience or you know, whatever, as you're reviewing Navajo Indian, you know, what's important in their culture that is it a health belief or something like that, a practice that they do that you could incorporate into the scenario? Diet, because they're at risk for diabetes, right? Not to do your work. I'll let you guys do your work, but does that help? Kind of direct? Okay. Any other questions? Because we're just doing this kind of fast, just to kind of apply what you've learned. And thank you. Be creative. Have fun. How you doing?
We're doing.
You're also deep in thought. You're reading.
We're trying to read.
Determining the line of how far is too far with our skit.
Okay, I know. I was going to say, you know, we have to be cautious, right? We don't want to come across being prejudiced, right? We don't want to ourselves.
So do you want the skit to entail a whole like assessment?
Well, it doesn't have to be the whole assessment, but kind of look at certain needs of that population. Like, you know, I could think of like imposition, like maybe I don't feel like it's okay for them to adopt a child, right? And I'm imposing my own beliefs on, wait, that child's going to be raised with two mothers? How's that okay? Isn't that child going to come under criticism? You know, and I'm imposing my own beliefs then on this, even though, I mean, you know, I don't want people to judge me. That's not my own personal belief, of course. Right. So like you said, we have to be careful with how far is too far. But that's something that we need to be aware of too, right? That.
How would you guys feel if like the nurse is delivering some kind of news, or we even have one of you guys play a doctor and they're going to deliver news, and then the partner is in the room with the patient? Bridget, did you decide you're going to be the patient?
Yeah, it can be. That's
okay,
fine.
So like, Selena, do you want to be Bridget's partner?
Sure.
There you go. Okay. So if like Selena's in the room and I come in and I mistake her as like just a family friend, and I'm like, would you mind stepping out in the hallway so I can, talk to the patient about this particular piece of information? And you're like, oh, well, she's my partner, we're married or whatnot. And I'm like, well, I really don't think that's appropriate. Like, I didn't expect that to be the situation.
Yeah.
No, that's good.
So Mrs. Erickson, how long does it have to be?
Just short. Yeah, just 5 minutes, or not even, just kind of playing it out a little bit. Little back and forth dialogue, whatever your objective is for, like, as you're looking over in the point, what are some of the key factors there to consider, right? That, we are wanting to be more inclusive, and how I think it is important to communicate that and share that with the team, right? So that people are aware that both, parents have joint custody, or what the situation is, and that they're, that this is a family unit in there, and not to, not to be blinded by it, or, saying anything inappropriate when they go in the room.
Right.
Mm-hmm. Okay. Yeah, sounds like you guys are on the right track though. So.
Awesome, thank you.
Yeah, what are some of the key points in the point regarding LGBT?
It talks a lot about communication and the verbiage you choose to use, and then the way you respond to their questions, and not to be blind to whatever their actual needs are.
Don't make assumptions that they are going to be a certain way.
Right. And so should we address, or would we ask, do you both want to be called mom? Or does the child both call you mom, or family member both? Like, isn't it just knowing what their needs are, what their what their wants, how they want to be included?
Right.
Definitely.
Okay. I like to have you get aware of this as a resource, right? Because I think a lot of times you have a lot of resources in the point that you could use in the future when you're taking care of patients, and use as a reference. So I like to kind of get you in there and get you familiar with this.
Yeah, I didn't know that it was here. It's like,
me either.
It's interesting stuff, isn't it? And then you got to look up your own background and see if it's true for you, right? Some of it is.
Let's see.
So do you want a child's situation as well? So like have Bridget and Selena be the moms, and then have kids or a kid involved?
Yeah, we could do that.
So there.
Hello.
Hello. How are you guys doing?
We're doing good. I think the biggest thing that we've identified as a problem is trying to get everybody a part in this.
Yeah, you don't have to have everybody have a part. If somebody's kind of taking notes, and whoever doesn't like role plays or whatever, they can kind of take the notes and things. Kind of be the leader. Yeah.
We were just discussing like typical stereotypes of a Mexican, so just like that they would require for translation because of the language, or maybe just assuming that they were Catholic because so many Mexicans are Catholic,
right?
Or just typical stereotypes, and then we're just kind of putting that together.
It happened to me, years ago with my first husband, my mother-in-law at that time. We were out at the Desert Museum, and in the loudest voice, she overheard these people speaking Spanish, and she said, I wish those people would learn to speak English. And I was like, Mimi, stop. Oh my God. They're probably bilingual. They probably understand everything that you're saying right now. I just, one of those moments you just want to climb under a rock and run away, not know somebody,
Oh no.
I know.
And then
it was
you
so
turn around and
embarrassing.
they were all Caucasian because this is Tucson.
Right. Yeah.
But on the other hand, I did used to work with a nurse and she was bilingual, but she refused to translate for her patients because she said, you know, me and my husband came here not knowing any English and we had to learn the language. So it'd be only fair to other people that are coming to the state just to try to familiar yourself, you know, with the language. So I'm like, and you know, she was of Mexican, you know, she speak 100%. That was her first language. And she was like, no, I think it's just people being lazy. Like they expect you to know their language instead of trying to learn ours. And she refused. She would not.
I did it. They can do it.
Yeah, exactly.
I think a lot of times people just get taken advantage of and they get tired of always getting pulled from their job and having to translate and having double the work, which isn't fair. You know, so that could just be her way of saying enough's enough, of having to, you know, do an additional job without being compensated for it. Yeah, but I think another stereotype too, what if you're assuming that they eat unhealthy and put a lot of lard in their food and they don't cook that way? What if they
Yeah, that's what we said too, like about the diabetes kind of thing, just assuming they all have diabetes because of the unhealthy lifestyle.
Right? Because I think that's kind of really judgmental, isn't it? You know, so.
Oh yeah. Well, and you know, like we were talking about just having a nurse come in and kind of take history and then, you know, just every answer, just kind of taking it in the most stereotypical way that you can, you know, like about what they eat, about what they drink, about what they're, you know, how they were injured or where their disease came from, like the diabetes. Like, I mean, there's, you know, prevailing myths like that for every kind of cultural group in, you know, that there is. It's for, you know, for Hispanics or Mexicans or Black people or Asians, Koreans, Chinese, like Canadians, you know, like everybody in Canada is the nicest person ever. Like, hey, you know,
right.
And they persist, you know, for everybody.
Right. Yeah. Or maybe that they're illegal. I hate that word, right? Undocumented.
I said
right?
that too.
I mean,
we brought it up, yeah.
Get really sensitive about, you know, words, right, that we use. So I think it's important to, you know, I mean, but you wouldn't want to assume, so wouldn't that be horrible if, you know, somebody's a citizen and they're working and everything and then they, you know, get judged as possibly being undocumented. But the thing is then you don't want to be judgmental against the person who is undocumented if they're coming here, if they were actually, you know, actually like fleeing from an unsafe environment and they were at, you know, they were here because they did qualify, you know, and had refugee status.
Sure. And that was actually kind of leads to one of the questions I was gonna ask earlier or wanted to ask earlier, but we were just kind of went through stuff in class so quick. Like, at what point does it cross over from, you know, trying to be culturally accommodating to cultural imposition, you know, towards the people that are there, you know, the staff in the hospital or the other patients and things like that? Like, how do we balance that? How do we, I mean, we do what we can, but at some point, you know, there are things that evidence-based practice just says, no, you can't do that. You know, no, you can't, you know, like you said, fry up fish in the, you know, in the latrine.
Right. Yeah. So you have policies in place and yeah. And you accommodate cultural preferences and requests as much as you can. Yeah. But yeah, you inform the physician also, right? So if they're taking herbal supplements that possibly could interfere, or they, you know, cupping or things that possibly could, you know, cause bleeding or issues, notifying the physician and incorporating that, because most people are going to go home and they're going to continue those practices.
Mm-hmm. Yeah, you're on warfarin or heparin. You really shouldn't be cupping right now. Yeah.
Okay.
So do you guys think that'll work? Like, just trying to do like a health history, and we can have, you know, 2 nurses still, and we could even, since we don't have to have everybody as participative, we can have, you know, one of the nurses kind of being
okay.
Good.
Oh, hi.
You guys have a plan, huh?
Monique got kicked out, by the way. She is trying to get let back in.
Okay, one unassigned participant. I wonder how, let me find her. Where'd you go, Monique? And she's going to be, what group? You're team 4, right? Or no, team.
We're 5, I think.
Okay, I gotta see. Oh, there she is. Okay. Okay, I think I got her coming. Hopefully she'll join. So it sounds like you guys are almost ready to roll, though. Are you?
Well, we had some questions.
Okay.
Do we, like we're on Zoom, so do we have to act something out, or can we just kind of go through a scenario?
Either way, if you feel like you're more comfortable just saying, here's our scenario, but if you can kind of, assign somebody to be the patient and the nurse, not everybody has to participate. You could just kind of go back and forth too.
Okay.
Okay. But if you really think with whatever you're doing, it would be easier just to say, imagine this scenario one day and just describe it. And that was your team. Everybody put that together. That's fine too. Okay. We're almost done. We're almost ready to go and run. Hopefully we'll have time for everybody to share, right?
Okay.
Okay, I think I don't know why she hasn't joined because I assigned her, so. Maybe she lost connection again. Okay. I have one more group to check with, and then I'll call everybody back.
Okay.
Thanks.
Okay, thanks.
Thank you.
How you guys doing? You almost set?
I think we got it.
Yeah, we're good.
All right, cool. Okay, I'm gonna go back to the main room and call everybody back then. Any last minute questions? Whatever you got, I'm sure it'll be fine. This is just a quick.
Are we presenting in front of the class?
Yeah. If we have time, for everybody, hopefully we can run through these kind of quick and just, get some key points. Okay, I'll see you back in class.
Do we leave?
Okay, I'm gonna close out all the breakout rooms. Everybody's coming on back. Okay. Okay, let's go ahead. Team 1.
Hello.
Hi.
Okay, so ours. Oh, go ahead. Were you gonna talk? Okay, go ahead.
I was just gonna say ours is about the doctor and the patient with family in the room. So basically, I'm the doctor, and I'm gonna ask all of the family members to step aside or outside the door because I want to diagnose my patient with what's going on, and I'm gonna assume that my patient wants privacy.
And then I'm the patient in this situation, so I'm gonna tell the doctor that I understand that he wants to respect my privacy, but in African American culture, having the extended family be a part of the care plan is really important. And then I would be the nurse advocating for the patient and explaining to the doctor. I'm sorry, I don't know if you want us to act it out, but okay. I would just be advocating for the patient and saying that the patient feels more comfortable with the family here, and trying to get him to change his mind about having the family stay in the room.
And then I would be the grandma, one of the family members, and I'd get really upset at the nurse and the doctor for trying to kick me out.
And I would be like the aunt's best friend's neighbor who's also there for support because they have a lot of extended family that's there when they're in need.
Okay, very good. So we got some key points, right? The importance for extended family, privacy. What are some other things that you read about in reviewing the point in terms of African American culture? Anything else? Any other questions from people? Was there anything related to diet that was specific for African American people?
Yes, they have like a high fiber diet with fish and pork. And we were talking about incorporating that in, but we weren't sure how deep to go with the amount of people we had. But that just to keep that in mind, if maybe they're not eating, or if their family, since they have a lot of family coming to support them, find out if they can bring cultural foods that they prefer to the hospital, I guess.
Would it be an accurate assumption to see who was making the decisions in the family, if it's a family thing? Because I don't know if this is me being biased or right, but I don't know why I have maybe this personal thing that maybe they're more matriarchal. Like sometimes the women maybe are more decision makers than the men, but I don't know if that's my own bias, or if there's truth to that. But I think with any family member, just knowing who makes the decisions would be important. But
So at least for African Americans, 28% of families are matriarchal. I don't know how to pronounce that, but where the woman is a household, it's usually like the grandmother.
Okay. So just something to maybe have in mind and consider if we're being culturally competent. Okay, very good. Okay, team 2. Good job, team 1. I know, we're just having fun.
Okay, so we are actually going to act ours out. So in this situation, I'm going to be the narrator. Brett is going to be our patient, and he is from Navajo descent, and Morgan is going to be our nurse.
All right, so this is me entering Brett's room. Hi, Brett, my name is Nurse Morgan. I saw that your call light is on. How can I help you today? Do you need anything?
And Morgan is making direct eye contact with the patient.
Hi, Morgan. I was wanting to see the Hatali.
The medicine man.
I'm not really sure what that is, but I'll get you a priest, okay? All right.
Okay.
All right, I'll be right back. Be there quick.
And Morgan exits. So for our scenario, basically we are showing cultural blindness because Brett wants to speak with someone in regards to spirituality, and Morgan clearly doesn't understand what that is and is like, oh yeah, I'll just go get a priest, and not even seeing that there is truly someone special that Brett is looking for.
Very good. Okay. Thank you. Yes, right? Yay. Team 3. We'll move right along so we all get a chance before class is over. Team 3.
We were working with LGBT community, and basically the setup is a child in the hospital and our hospital staff has not actually bothered to inquire or review family dynamics.
Good afternoon, Ms. Gary. I'm Nurse Chanel. I'm here to talk to you about your son's diagnosis. And I was just wondering if your friend could go ahead and leave the room so I could talk with just the fammy.
Oh, she is.
Mom. I'm sorry?
That's my other mom, not a friend.
Oh, I would prefer personally to just speak with the biological mother.
Well, I'm sorry to tell you, but just because he didn't come out of me doesn't mean that I'm not his mother.
My apologies then. I will go ahead and find go speak with my charge nurse about this matter. I guess that's it. I don't know. Ms. Gary, do you want to say anything else?
No.
Mom, come on.
Chanel, you weren't very nice.
Hey, we had to tone her down. She wanted to be a lot meaner. We had to bring her back.
No, that's good. No, but it makes a good, point when you're doing it wrong, right? We all can be like, how would they feel, you know, if you were in the hospital with your child and that happened to you, right?
For my credit, I would never do that.
I know,
would,
I know,
okay.
that's how I feel too, you know, right? Isn't it hard? It's hard to even, I feel like sometimes it's hard to even talk about this because, you know, we don't want to offend anyone, right? As nurses, I don't think in our heart, we would never want to hurt or offend anybody. And yet when you're going down this road, it would be so easy to do without even intending to do it, you know? So I tell you, I still learn with my life experiences going along. You know, you can imagine through the generations, you know, how we've had to become more just, you know, aware of people and, you know, people's uniquenesses and values and beliefs and incorporating them into our care. So this is good. Okay, team 4. Good job.
Okay, so we had Hispanic stereotypes. I think we're group 4. I hope so.
Yes, you are. Yep.
Okay. So there's going to be 2 nurses, 1 patient, and then we're going to bring in the translator because we're automatically assuming that they only speak Spanish. So, and then Tom's going to be the dad of the family.
Because I'm old.
Super old.
Okay, so in comes the nurses, and Yasela's the patient. And we ask her, like, so Yasela, are you diabetic? Because we know that, you know, you eat a lot of, the Hispanics eat a lot of fatty foods, and, you know, do you have hypertension associated with it as well?
Well, our diet kind of consists of unhealthy food, but I'm kind of doing better on that. So I guess you can attribute diabetes.
Wait. Who is this lady?
Yeah.
Who is this lady over here being all quiet? Why is she in here? You guys are the nurses. Why is she in here?
I was brought in to translate for your daughter.
Who said we needed a translator?
I was told by the nurses, and I'm just doing my job.
Maybe you tell them that you needed a translator? Where did they get this crazy idea?
No, maybe because we're Mexican?
What? Okay. Moving on.
The next question would be, do you drink at all? Are you a heavy drinker?
No, I'm not a drinker.
My daughter's only 19. Why would she be drinking?
I'm not quite sure.
And scene. All right. We tried to make it so that everything was interpreted through the most stereotypical lens that we had. And we also know that Mexican culture is predominantly patriarchal. So we had an overbearing, angry type father.
Very good. Okay. Very good. Okay, so let's move on to team 5, homeless community. Good job, Tom. I can see the natural acting ability there, right? Yes. Homeless community, you're up.
Yeah, we had homeless community and bias, and I really hate to follow all of you guys because we just have a scenario. Basically, a homeless man would be brought in, let's say, for heat exhaustion. And then when the nurse initially sees him, she just automatically assumes he's probably doped out on drugs and has no health coverage, is probably going to be difficult to work with, maybe violent, schizophrenic. So she's just not, you know, really excited about helping this gentleman.
Mm-hmm.
Yeah, some of the things that are important to know about the homeless culture is that they are kind of a refuge for pretty much anyone that's rejected from other cultures, and they tend to be a close-knit group. they do sometimes look at violence as normal and sometimes solve their problems through violence. Also, some things, if they're on the streets for more than a year, they're considered chronic homeless. And so those are just a few things that, that are usual in a homeless community.
What else did you read in the point? Do people who are homeless choose that life? Is it like a lifestyle that they choose, or is it usually because of temporary circumstances that force them into homelessness?
I think there are various reasons, but it's very common for them to have a story. And so I think it's just everyone has a different reason for being there and has a different story to share.
A lot of them have, you know, just the lack of support system in place. A lot of military veterans, or I did read that 40% align with the LGBTQ community, which surprised me. So just people who just don't feel like, you know, they have anywhere to go or anyone to support them.
Right. Both are really marginalized populations in our society, aren't they? Interesting. Okay. Very good, guys. Good points. Yeah. Or they don't like being called homeless. People experience, and that's so true of anybody, whether it's a situation or a disease, right? We don't want to say that diabetic patient, right? That person with diabetes, that person who's experiencing homelessness. I think as nurses, we need to kind of reframe what we say, because what we say reflects our attitudes and our heart and our beliefs, right? So that's where we got to be careful with our words. I'm speaking to myself too. I'm reminding myself. Okay, team 6, finish us up for the day. Iranians in blindness.
Okay, so for our but for our situation, we have Rachel as the nurse that is showing blindness to the Iranian patient who's Vivian, and then we have Shelby as being the mother of the patient, and Tamara as the sister.
Hi, Vivian. I'm Rachel. I'm going to be your nurse today. How are you?
I'm fine, thank you.
Okay, cool. I just wanted to let you know you have physical therapy scheduled for 9 a.m. this morning.
So I have prayer every day at 9 a.m. Is there any way that we can reschedule physical therapy?
No, I don't think so. That's when we have you scheduled. That's when they come around and do that. So it's going to be really hard to get that changed now.
Do you know if the physical therapist is a male or a female?
Nope, I have no idea anything about their staffing down there, who's scheduled, so.
Well, it's just really important for it to be a female, considering my daughter is female. It's just, we don't like males touching other females in our religion. It's more same sex of what we want.
Yeah, I don't know. I'm just gonna start your head to toe assessment right now, and then I'll look into that for you and see.
So for like our situation, we're trying to show that Rachel's kind of ignoring like the religious preferences of her patient with not trying to move the physical therapy around, and also trying to ignore any concerns that the family has, because family for Iranians is like their center of their emotional and social life. And then I forgot what the third one was.
The male, female.
Oh, yeah, they prefer to have the same same-sex healthcare providers. But we were just trying to show that Rachel kind of just ignoring all of those, not really concerned about any of those patient preferences.
Yeah, and Rachel, you did a really good job. Didn't you do a good job? She's just like, nope, I'm gonna do your head to toe, and I'll look into that later. It's like, good job with this. Thanks so much everybody for playing along with me. So remember that week 3, so kind of this review stuff, right? Chapters 3, 4, 5, 6, chapter 28 on complementary and alternative medicine. Do your prep use. I'll get out a study guide that will kind of, really something that you can focus on and know that will be, a good reflection of what's going to be on the test. Okay. Nice job kind of working together and applying this and, showing me that those assessment skills and just interacting with each other. I like it, right? Any questions? So there's no outside assignment or discussion board. What I'm expecting is for you to focus on prep use and focus on your study guide. If you want to send me the study guide, if you finish it early, I can look through it and let me know, I'll let you know if you missed like a section, if you overlooked anything. I'm not going to give any answers away, okay? But I will just say, looks good to me, or, there was a second part to this, go back and look at it again, okay? If you get it to me too late, though, no guarantees. I'm not going to stay up after midnight. I know, but I might be up after midnight. I did read a few discussion posts last night in the middle of the night, so, but no promises. Okay, so thank you so much. Okay, I know these 3-hour lectures can get long. Don't worry, as we move forward, and everybody's frozen, so, oh, there you go. Okay, so I'll just say goodbye, okay? I'll hang if there's any questions, okay? Otherwise, have a great evening. Keep studying and reading. Thank
Ms.
you.
Erickson?
Yes.
So our exam is next week or the week after?
It's next week, week 3.
Okay.
On chapters 3, 4, 5, 6, 28. Study guide's coming out. Then we'll move on to oxygenation. So we want to have the test on all this stuff before we move on to oxygenation. Melinda, nice job sharing your experience with homelessness. Have you worked with the homeless population?
I have not, and in fact, I don't have any medical
all that was
experience.
Just what you reviewed in the point, huh?
It's what I read in the point. I have a sister that did experience a brief time of being homeless, and just kind of, so there's a little bit but she's in a different state, and I don't have a lot of contact to be able to talk to her much. So
but you just did such a nice job of sharing that information.
Oh, thank you.
Yeah,
Appreciate
you have a good clarity in your voice and teaching. You'll do well providing patient education.
Oh, thank you. I appreciate it. This is hard for me, actually. The role playing, I was just telling my group that the role playing is really, really tough, and not having any medical experience going into this. I was thinking I was going to something that might be playing towards my strengths, and then I realized that all of it is having to strengthen my weaknesses. So it's hard for me.
No, but let me just encourage you. You did really, really well.
Oh, thank you. Appreciate it. Okay, so my question I think has been answered. I just was wondering about the exam. So is there a study guide then out that we can print up then and do?
Not yet. I'll be posting it. I'll send out an announcement once I've posted it. I just like to go over after I give lecture, I want to make sure I've covered everything. And if there's any changes I need to make, I just give it one more look over and everything. And then I'll be getting it out soon.
Okay,
sometime
sounds great.
Tomorrow, and I'll send out the announcement. You'll have it in plenty of time.
Okay, sounds great. Thank you.
Thank you. Yeah.
Ms. Erickson?
Yeah, yes.
I was just wondering something, like just kind of almost not right off topic, but you were talking about the group in World War II and the benefits. Was it the Marshall Islanders you were thinking of?
No, it was
the
Hmong population. So they were up in the mountains, and they helped almost work like secret agents and things, and gave fed information to our military troops.
Okay, I was just wondering because we did stuff with the Marshall Islands too, and they get at least access. They can come and go across the borders because we basically ruin their islands.
They specifically speak Marshallese,
Mm-hmm.
and that's a fun language on the interpreter phone.
Yes, it is.
It's colorful. It's a colorful type of language,
Absolutely, yeah. Like I said, I worked with DES, so yeah. So I was just wondering if it was the Hmong or if it was Marshalls. So.
Yeah.
Okay.
Yeah. But yeah, I'm sure as we look back in history, we've worked with a lot of indigenous populations, and
Yeah, and I wish they got
important allies, right?
Right. I wish the Marshalls got more than just the ability to come across the borders for what we did to them.
Isn't that the thing? Is then taking advantage of some of these populations and then not holding true to our word and what we might have promised them too.
Yeah, and then we saw a lot of the whole adoption scandal thing going on too, so that wasn't good either. But thank you for clarifying. I appreciate that. I was just curious.
Yeah, I'll have to look that up again, and I'll get back to you on what war that was and what I remember it talks about it in the book. It gives that history in it. So, and I had a copy of the book, and then I donated it to the PMI library too. And then some of the nursing students were checking it out and stuff. I should get another copy for you. you know, like on Brick, 'cause it's an excellent, it's really interesting book.
Okay, no, I wrote it down. I'm gonna look it up and stuff. So
Yeah, thank
okay.
you.
Oh, thank you. Have a good
Nice
day.
talking
Bye.
to you the other day too.
Okay, bye.
Bye. Hi, Sarah. How are you doing?
My computer froze with like for a second. So did you say you wanted us to turn in the study guide so that you
No.
can review it?
You don't need to turn it in. I just said if you get it done early enough and you want to
Okay.
send it and have me look it over and give you feedback, letting you know if it looks good or if there was something that maybe you should go back and review. I'm not going to give any answers away, but I am willing to just give it a quick look over and see if anything jumps out to me that you need to go more in depth on.
Oh, awesome. So do you want that like through email or is
Yeah,
it somewhere?
yeah.
Okay.
Email is great, and then I can just
Okay.
I'll give it a quick look over and say, you know, great. Yeah, just study what you got. You're good.
Okay. Awesome.
And
Thank you so much.
Do you have another specific question about the discussion board? Was there something that was unclear? Because I feel like I'm, you know, like the grading, I'm finishing it up. I'm still not completely done with it, but
Yeah.
you
No,
know, like
I was just with the references, just because it's kind of hard to keep up with everybody's, you know, requirements, like, you know, references or no references. So I just kind of wanted to get something kind of written down so that I can always just reference back to. So
yeah,
I
but
just
I'll try to include that in the directions for each assignment too, and be more clear on it. I think you had emailed me too, and I
Okay.
said not necessarily. It's not really.
Yeah.
Yeah. I don't mean to be vague.
Yeah,
I guess I was kind of being.
Yeah, it's kind of, you know, hard keeping up with everything, but yeah.
Mhm.
Thank you so much. Have a nice evening.
You too. I loved your discussion posts.
Oh, I'm glad you did. Thank you.
Yeah.
It was an interesting video. So yeah, definitely. It's nice to kind of get exposed to that stuff, you know.
It you know, you guys really did think it through well. So tell Hassan I said hi too, okay?
Will do. Thank you so much. Have a nice evening.
You too. Bye.
Bye.